The saying goes, tell me and I forget, teach me and I may remember, involve me and I learn. We, the Department of Pharmacology, Kilpack Medical College, are making an attempt to involve you in a webinar on pharmacotherapeutic walkthrough in the prime epochs of life. We welcome you all. We are starting with the academic session. It gives me immense pleasure to welcome the first speaker of the day, Dr. P. Ramesh, Geriatric Consultant in Bunbury Regional Hospital, Australia. He graduated from Stanley Medical College. He is a fellow of the Royal Australasian College of Physicians, Royal College of Physicians, and holds a postgraduate certificate in education in UK. He has his interest in dementia and in the development of telehealth and assessment techniques. He is the president of the Southwest Indian Group of Australia, which was involved in many philanthropic activities, including fundraising for purchasing oxygen concentrators during tough COVID times. We welcome you, sir, to share with us a clinician's perspective on geriatric pharmacology.
Since Dr. Ramesh couldn't join live session due to his commitments and the time lag between the countries of Australia and India, we are now going to show you the recorded session done by Dr. Ramesh.
I'm a specialist geriatrician and physician at Bunbury and Western Australia since 2011. I've qualified from Stanley Medical College along with Aruna, and I've been practicing around the world before settling into the warm sunshine coast of Western Australia. And as you know, there is a strong indigenous tradition and culture around Australia.
Sorry for the disturbance, we have connected it again, some net issues. Now we'll be able to hear the session. We'll just begin.
And in my perspective, perspectives on pharmacology. My perspectives on pharmacology in the elderly will be talked through the presentation. But before we delve into that, I'm also going to talk about this slide where you can see this is the Bunbury Coastline. And it's where this is actually this is the aerial shot of the Bunbury Coastline. When we first arrived to Bunbury, this was how I fell in love with this place, which is about 2 hours from Perth. And this photograph was actually taken by one of my patients who had advanced Parkinson's disease at the age of 50 and was interested in photography and gifted a photo atlas of Bunbury through the various parts of the history in the last 50 to 80 years. And I did try to take a shot when I was learning flying, but sadly had to give up after 60 hours after stalling the plane a couple of times. Well, that's enough about me. Pharmacology, medication errors, and medical negligence, it's a thematic issue that the media likes and is always hungry for more and more stories. Irrespective of which part of the world you are, it tends to attract more media attention than anybody else's any other stories. This is global. It's not just specific to India. It's not specific to Australia, specific to US. Everywhere it happens. And irrespective of how many patients you have treated and successfully discharged alive to the destination, it's that one patient that you had made an error, be it human or system error, that always affects the health and well-being of the medical professional, as well as leads to unnecessary media bias. So in this talk about my perspective regarding the pharmacology in the elderly, I'm going to briefly give you a few case scenarios that we can discuss at the end of the presentation, followed by some of the common thematics in medication errors and a new evolving concept in the last 10, maybe 20 years called drug burden index, and touch upon briefly about polypharmacy and talk about the risks versus benefits of prescribing versus deprescribing, and the two common tools that I use, and I will give you some apps for everyone to have a look at in their own time, and touch upon deprescribing and then go back to the case scenarios. And I'm conscious of the time allocated by Aruna to me to keep it around 30-35 minutes, so I will try and stick to the time limit. So just from the case vignette 1, this is Mr. RS, a 75-year-old male who's a non-smoker, consumes alcohol, 1 glass of wine a day, attends ED with the chest pain. ED is emergency department, attends with chest pain, ST elevation MI, seen by the cardiologist in CCU, and commenced on dual antiplatelet, had a stent, beta blockers, statins, which is pretty much a box standard treatment, I suppose. During the inpatient stay, was found to have late onset diabetes, was commenced on dual therapy for the diabetes management. A week later, went into acute pulmonary edema, was commenced on Frozomide, Spironolactone, along with those above medications, with a planned review by the cardiologist in 3 months, and the dual antiplatelet to be reviewed in 12 months. He was subsequently admitted to emergency department 2 months later with a fall and a confusion, and was found to have had a hip fracture. So was commenced on calcium vitamin D, denosumab injections as a bone protective therapy. Now readmitted 4 weeks later with an acute confusional state, falls, CT head was abnormal, with postural hypotension noted with a systolic blood pressure drop of more than 30 mmHg. So he was seen by the medical team in the surgical, in the orthopedic ward, and was commenced on fluorocortisone. And patient was discharged a week later with on discharge medications of dual antiplatelets, statins, beta blocker, aspirin, clopidogrel, Frozomide, Spironolactone, fluorocortisone, oral antidiabetics, calcium, vitamin D, denosumab. Just keep it in mind that this patient was admitted a few months earlier on no medication, and to the number of medication he is on at the moment. Case we need 2. This is Mrs. EB, was 85 years of age, presented with memory loss and background history of osteoporosis to the memory clinic. Was commenced on donepezil, initially at 5 milligrams and then to 10 milligrams, following a diagnosis of Alzheimer's disease in 2020 by us, with an MMSE of 20/30 and a MOCA of 16/30. She was subsequently admitted via ED with an acute confusional state, with incontinence, urinary tract infection, and delirium. Patient was commenced on antibiotics, and then subsequently was initiated on oxybutynin for incontinence, and she was admitted to acute medical ward. The final case scenario I'm going to discuss at the end is Mr. LB, 80 years of age, diagnosed with Parkinson's disease 7 years ago, with presence with memory loss 2 years, and was commenced on Madapar 200/50 4 times a day, is on supplements, fish oil, COQ10, and is ambulant with a 4-wheeled walker, and was admitted to emergency department with an acute confusional state, agitated, aggressive, vomiting, dehydration, sepsis suspected with constipation, admitted to the surgical ward as there was a concern about a bowel obstruction, but excluded on CT abdomen and X-rays. During his inpatient stay at a surgical ward, was found to be agitated and assaulting the staff, and hence was given haloperidol by the night duty doctor for the agitation, and metoclopramide IM for the nausea and sickness, and patient was kept on nil by mouth. We'll come back to these scenarios at the end of this presentation. Just touching upon the medication errors, as you probably gathered, this is an infographic from World Health Organization looking at the various locations of medication errors and what are the commonest type of medication errors. In the video, in the slide on the left hand side, you can see that there is a graph presents various locations and various reasons for medication errors, And on the center of the graph, you can see the total errors, which is about 237.4 million case errors, of which predominantly the share has been between the primary care settings, care home settings, and followed by the secondary care settings. And the intention from the World Health Organization is to reduce such errors by at least 50% in the coming years. So sometimes this is true, what the slide is portraying. I have had instances where the patients have accidentally or voluntarily stopped the medication and felt better than what they've been. We've all been through this. So next I'm going to talk about drug burden index. Drug burden index is defined as a pharmacological measure that quantifies the older adult in relation to the side effects and a physical cognitive function, for example, such as anticholinergics and sedatives. And it's coming into use quite widely at the moment, and it's something we need to keep it in mind when we prescribe medications to the older adults. As you all know, drug burden index is quite a significant factor. For example, when we did a small audit in our local hospital and in England, we established how the exposure to anticholinergics and sedative burden is associated with 60% of increase in fall-related hospitalizations, increased risk of memory loss and confusion in somebody who already has cognitive impairment, and how the combination has an increase in mortality for older adults. And there's been consistent data that shows that in this population demographic studies, increase in number of medication increases is an independent risk factor for falls. And of this, the SSRIs were associated with highest risk of multiple falls amongst all psychotropic medications. And this is pretty much similar to whichever part of the world we are. Is the moment you increase the number of medications to more than 4, there's an absolute increase in risk of falls. So one of the things we forget is the common drug interactions that happens with the different medications initiated by different specialists. For example, de novo patient coming into emergency department with chest pain, gets seen by a cardiologist, commenced on usual combination of statin and antihypertensives, lipid lowering, and other measures initiated. Then has a coincident frailty or osteoporosis, gets a bone protection, followed by reflux symptoms due to the bone protective medication, followed by late onset diabetes or other illnesses. And before you realize, the patient could end up being minimum of 10 or 12 tablets, and add to that another few tablets the patient takes from over the counter. So drug interaction is defined as the alteration of the pharmacological effect of a drug in the presence of another drug. This is where the synergistic effect of drugs, it turns into the antagonistic effect of one another. I'm not going to go through delve into each and every of these lists, but some of the common things we see, especially in the older adults, is the commonest combination of anticholinergic drugs for incontinence and in the presence of cognitive impairment and delirium, and also in the presence of acetylcholinesterase inhibitors for the dementias, and the use of antipsychotics in Parkinson's disease, the commonest culprit being haloperidol, risperidone, and other medications that we use. There is a treatment cascade, which I'll show later, where patients who commenced on non-steroidal anti-inflammatory drugs then tends to have developed leg edema due to fluid retention, and then gets commenced on thiazides with coexistent postal hypertension and a flare-up of a gout or and other side effects with hypokalemia and so on. So I'll just touch upon some of these common interactions. As we know, digoxin and frozomide, it's been established for some time for AF and cardiac related issues, as well as long-term morbidity studies have showed digoxin is better in reducing the hospital admissions, but with no effect on mortality, but reduction of hospital admissions. However, digoxin effect or digitoxicity is a higher risk with somebody who's on frozomide and has hypokalemia. Another combination we keep coming across is somebody who's on spironolactone and potassium chloride combinations. So this is a cascade that we can refer to, and once again, in the interest of time, I would not go through each and individual medications, but I'm happy for you to have a look at it at your leisure. So I just want to touch upon this is a very important tool for all of us, especially the postgraduate students who will be practicing medicine in the elderly, irrespective of whether they're qualified as a geriatrician, as most of the acute and adult medicine and involves old adults at any age and any stage. McBeer is a geriatrician who, in conjunction with the American Geriatric Society, devised this criterion-based medication review to reduce adverse drug effects. The beauty of this tool and the criterion-based decision making is it helps you to decide about the anticholinergic effects or adverse drug effects and drug interactions of the common medications that we use. This is probably useful for all of us. I will touch upon the app that incorporates all of this towards the end of this discussion. And I would invite you all to go through this list, which is quite extensive, but I think it's also useful to have a glance over, especially when you're going to be using it for your medication prescription in the elderly older adults. So I wouldn't go into each and every slide on this one, but I would suggest you have a look at it and see how we go for how you use it in your day-to-day clinical practice. So similar to this, there was an UK developed version of the criterion-based decision making, which I'll come back to that in a minute. This is what we talked about earlier on in my presentation about non-steroidals having an adverse drug effect, which is the edema and hypertension, and then being commenced on thiazide for managing the adverse drug effects that's come from non-steroidals. As you can see, this is pretty much quantifies the drug interaction definition. We treat a side effect of one drug with another drug which has its own side effect. So adverse drug effects is a common problem. As you know, almost every medication has an interaction and a side effect profile, but in choosing wisely, we should be able to address most of this medication. This applies not just to the geriatric age group. I think it applies to all the age groups that we manage as physicians and clinicians. So this is the current thematic issue that's very popular in Australia at the moment, the polypharmacy. As we talked about earlier on, there are patients who take several tablets which either have been forgotten as a prescription for some time, like especially in Australia, we have a lot of the analgesic medication that was prescribed for a soft tissue injury that happened 3-4 years ago, but still stays on the prescription as a repeat. and the patient continues to take, because most of the patients, just like everywhere else, tend to rely on the doctors to suggest whether they should be stopped or continued. But if we, as in a busy practice, forget to advise, they continue taking them. I have a record of one patient who was only 55 with advanced Parkinson's disease, was taking 140 tablets a day, and of which only 20 were relevant to a Parkinson's condition as a split dosing through the day. But remaining were really over-the-counter supplements or medication that she was taking through various other reasons, from injuries and other aspects that's created several years ago. It took us about 2 weeks to bring it down to 20, and she's managed well. If you look at our formula where we talked about patients taking more than 4 tablets at any time per day, have an increased absolute risk of falls, and she would be fitting in despite being age 50 because of her Parkinson's disease. So this is the treatment cascade we use for our trainee doctors, where we say what is the original decision making involved in the prescription of a drug, and what is the current expanded version that we should be looking at. Is not just concentrating on the prescribed medication, but also look into the over-the-counter medication that patients are taking, that we, in our busy practice, sometimes forget to ask them. So this is very topical at the moment: prescribing and deprescribing. Deprescribing is defined as a patient-centered process of medication withdrawal intended to achieve improved health outcomes through discontinuation of one or more medications that are either potentially harmful or no longer required. Deprescribing is not a single one-off process. It's a continual process that needs to be implemented, followed throughout the patient's journey, especially those who are over the age of 75. And we have established on multiple pilot trials, and we have also looked into multiple studies around the countries, including US and various other sites, where deprescribing could be done in an efficient, collaborative way between the primary care, secondary care, and also the communities. And deprescribing is more efficient if done in collaboration with the patient, keeping the patient as in the center of the focus, so that he can reason out and justify the causes of the medication, the causes of the side effects, the causes of the reasons for deprescribing. And have been involved partly in a pilot trial some time ago, where there was initial antagonism from the local primary care practitioners, but once we reasoned out the benefits versus risk, it helped us. We're not there yet. We still probably managing to deprescribe maybe 10% of the population, but this is something we can make a conscious decision to review those medications. This is another tool that's been widely used in various parts of the world. It's originated from Europe. The stop and start tools. The stop is a screening tool of older persons' prescriptions, which is another criterion-based decision-making tool in prescribing, and also helps to address the drug-to-drug interactions. Then the other side of this is the start tool, which is a screening tool to alert doctors to the right treatment. It actually addresses the medication that could be used and should be utilized in patients with specific medical conditions, meaning it eliminates those unnecessary prescriptions or unwanted prescriptions, as well as using the right choice. Once again, going back to the theme of choosing wisely. There has been various arguments about the two different tools versus BS criteria, which is an American-based tool, and stop and start. I personally do not feel that there's not significant difference. It all, in a way, to me, it appears that it's a common sense medicine in the background of evidence-based medicine. And I always say there might be evidence-based, but there is also common sense medicine we sometimes forget to practice. For example, considering a statin therapy for somebody who's 95 or 100 years of age with a limited life expectancy, I think some of these will help us to avoid unnecessary harm done by these some of those prescriptions and drug interactions. So we're nearly coming to the end of my presentation, but I just wanted to talk about the case vignettes that I presented earlier on. The first one is a case vignette 1. We can all see that this patient who was admitted on no medications has been discharged over multiple admissions with multiple combinations of pills. But in this case, all we managed to do was we trimmed down the frozomide to the lowest dose at 20 milligrams, stopped the spironolactone, and have managed to withdraw the fludrocortisone, continued with the bone protection therapy as the patient's vitamin D and DEXA scan were consistent with osteoporosis, managed to negotiate with the cardiologist to consider reviewing the dual antiplatelets, and also the diabetic management was revised. So in the end, the patient was discharged just on the single dose of clopidogrel and reduced dose of frozomide, stopped the fludrocortisone, and continued the bone protection. And the diabetic control was switched on, so we managed to revise the anti-diabetics to a single dose medication. So this goes to show that how we treat one drug interaction with another drug, creating another side effect. And this is, we all do it. I, as a geriatrician, we still come across where there are medications that we think this patient could have been trimmed down to single or a minimal number of medications. And probably we're not there yet, but we're getting there. The second case we need is somebody, which commonly happens, is a patient with Alzheimer's disease or cognitive impairment, being admitted to an acute medical or surgical ward with an acute confusional state, generally due to sepsis, and is already on a cognitive enhancer and being commenced on common drugs such as oxybutynin for the incontinence, without being aware of the interaction between oxybutynin or acetyl anticholinergics in the elderly, full stop. So anticholinergics in the elderly are definitely contributed to confusion, cognitive changes, and delirium in the setting of acute infection. One of my common prescribing that we do is to looking at the medications that patients take for the continence. And we moved more into interventional therapies for incontinence in quite a few patients of mine. And one of the things we constantly go and stop on my pediatric patients is the oxybutynin. And some of these incontinence medications have shown to have chronic cognitive changes, even with slight worsening in the acute setting, such as UTI, delirium. So in this patient, unfortunately, this patient was a sad scenario because the patient was catheterized, was commenced on all this combination medication, and tried to get out of the bed in the middle of the night because she became more confused with the delirium and the incontinence and the oxybutynin, had a fractured neck of femur, and sadly ended up with a pressure ulcer and was transferred to a nursing home, despite having functioned well with the memory loss in the community for a few years. The final case vignette I wanted to talk about is the Mr. LB, who's 80 years of age, again a patient of mine. with advanced Parkinson's disease, but managed with Madapar as he was responding well. Had mild cognitive impairment with an MMSE of 24 with a MOC of 21, and was managed on Madapar and was taking supplements such as fish oil and COQ10. He was ambulant with a four-wheeled walker and was independent, self-caring with no services involved. During his admission last few months ago with an acute confusional state, he was found to be agitated, aggressive, assaulting the security staff and the nursing staff, and was also found to be dehydrated and was vomiting. A diagnosis of sepsis was made with probable underlying constipation and dehydration. An abdominal X-ray and CT abdomen ruled out obstruction. A CT head ruled out any intracerebral pathology. As there was still a suspicion of subacute bowel obstruction, he was kept nil by mouth. In the middle of the night, patient was given haloperidol because of his agitation, and also given a stat dose of metoclopramide for his vomiting and nausea. Sadly, the next morning I was called because the patient became drowsy and almost reaching to the stage of comatose, and was also rigid because as he had not been on this Madapar for 24 hours. Unfortunately, despite commencing on apomorphine infusions and supportive treatment, conservative management, he did not recover from his haloperidol and remained sedated and became comatose at 24 hours later, and also had severe extrapyramidal syndrome due to his metoclopramide. And sadly, despite active management in the high HDU, he still did not progress well and died with an aspiration pneumonia. So this is somebody who's been functioning well for some time in the community with this Parkinson's disease. Once again, the culprits here, the haloperidol, as we all know, it's a contraindicated drug for patients with any evidence of severe cognitive impairment of Parkinson's disease, especially Parkinson's disease, as it induces severe rigidity that sometimes never gets them back to their normal self, irrespective of medication adjustment. The metoclopramide, commonest side effect is extrapyramidal syndrome. Once again, not a drug that we should be using in patients with Parkinson's disease, and especially considering this patient was supposed to be having possible subacute bowel obstruction. Unfortunately, this is one of the sad scenarios that happens because of prescribing practices that does not factor into the older adults' physiological, chronological issues, as well as the medications and drug interactions that the patient is on. So this is something we always teach our trainee doctors and teach ourselves as well, is looking at this wheel of fortune, we call it, starting from what is the beneficial and non-beneficial therapy, and address what's relevant for the patients, what is high risk initiation in the old adult, and match it up with the functional status, the cognition, and are we clearing any adverse effects due to their renal functions, due to their compliance, due to the comorbidities. So I suggest to most of my trainees that make your findings, make a diagnosis, simplify the drug regimen, and look at the risks versus benefits in treating somebody, especially over the age of 65. But I would say in the Australian population, we look at over 75 as the geriatric population, despite the definitions of over 65 being the geriatric age group. So I think this is quite a relevant slide. and something which may not be a bad idea to have a pin up in your clinic room. So it gives you a constant reminder, and see how we go from there. So this is a tool that I would suggest to all of us, especially the postgraduate trainees. It's on Google Play Store and App Store as well. This is the tool I was talking about earlier on, which is a Stop Start 2015 along with the BS criteria. It's a very useful tool. It gives you all the drug interactions that you can get from your app before you commence somebody on medication. At least it gives you a cautionary note. And then you can make a clinician judgment call on whether this patient needs to be on a medication that you think is relevant for the treatment. And I think it's very useful. I would suggest you have a look at this. I'm not promoting it or suggesting it, but I still have it on my phone that I sometimes use it, especially when I have patients who are being seen by multiple specialists with multiple comorbidities. And I think it's important to have a look at this. So we're nearly coming to the end of this presentation. We started with the Noongar word kaya for hello. In the Noongar and the indigenous tradition, they don't really say thank you as a customary thing. They have two words. One is yanga, which means thank you, and buja, which is goodbye. And I think I had pleasure in putting this presentation together, which is away from my normal clinical case presentation or research articles. And I hope you enjoyed it. I have put my email address for anyone to contact me with any suggestions or queries. I'm more than happy to be contacted. Once again, thank you all for giving me an opportunity to present one of my favorite parts of the world, Chennai, and good luck to all those postgraduate trainees in their attempts for becoming a safe and established clinicians in the future. Thank you. Bye for now.
So I request you to share the queries in the WhatsApp group or through mail. We can send it to Dr. Ramesh and get the answers and share it with you all. So with that, we will proceed with the next session. Before that, small announcement regarding the quiz. I request Dr. Kirtana to tell you about that.
Like as announced earlier, we are having a quiz, and as communicated, there are about 30 questions totally, 10 questions per session, like 10 questions for pediatric, 10 questions for geriatric, and 10 for the obstetrics. We see that we have announced prizes, and it is a cash prize of around 500 for the first part, those who take up the first position, and 300 for the consecutive next two places. 40 participants, and we are expecting as much as response from you all. And each quiz will be in between each sessions. Like say after the geriatric part is over, after the next session, we'll be having the quiz for the geriatric. 10 questions will be projected. You people can answer from your login screen itself. You need not go in for another screen or anything. And 30 seconds will be given from the time of projection. 30 seconds will be given for each question. If there is a tie, based on the time of response, the seniority will be taken. Now I call upon Dr. Jayasudha ma'am for introducing our next speaker. Good morning all. Good morning all. It gives me immense pleasure to introduce our next speaker for the day, Dr. Ramchandra Bhatt sir, Director, Institute of Pharmacology, Madras Medical College. Sir has more than 20 years of experience in pharmacology, and he has been the head of Department of Pharmacology, Epoch's Medical College for more than 10 years. We are happy to have you back, sir. Sir is a member of various institutional ethics committees, and he has participated in ICMR trials. He has been a subject consultant to the Drug Controller General of India. Sir has many publications to his credit in prestigious journals. His areas of interest include medical education, research methodology, ethics, and rational drug therapy, and also geriatric pharmacology. Sir is instrumental in establishing the Pharmacovigilance Center in Epoch's Medical College and training many professionals in the area. And the Pharmacovigilance Center in KMC has received many awards under his regimen. And he has attended a training program on elderly care in Thailand. We welcome you, sir, to enrich us with your expertise in pharmacologist perspective on geriatric pharmacology.
சரி, இதை பார்த்து பேசுங்க கொஞ்ச நேரம். அங்க
Very good morning to all of you. Let me first thank the organizer, Dr. Aruna Madam, Professor HOD of Epoch's Medical College, for giving me the opportunity. Let me also remember the contributions given by Dr. Malar Sivaraman, former professor of the department, and later she became director. And I'd like to thank also all the subsequent batches of assistant professors and postgraduate students who have brought up the Department of Pharmacology, KMC, in a very nice manner. It's a really immense pleasure to be here physically and address the gathering organized by Dr. Aruna. So let us see the basic concepts which are underlying in geriatric medicine, about which we have seen in the earlier lectures also. So this is the basic starting point in this elderly pharmacology we call. So as everyone is living longer in today's world, we don't know the cutoff point whom to call elderly. In fact, all are young nowadays. So now books are shifting towards this definition of 70. Of course, they cannot tell 18, 85 as elderly because they are more elderly. So maybe we can settle for a compromise that at around 60, you must be cautious. At around 70, treat as elderly. at about 80 and 85, we have to give special care for them. So in this way, we have to give these 4 decades special care for every individual, right from the age of 60. Now, why it's all important, geriatric care? Because if you take the survey, 12% of the population, they are consuming 32% of the drugs. And similarly, if we calculate how they utilize the infrastructure in terms of surgery or bedside care or all other social support systems. In fact, we all know, we need not to think much about this, that this part of the population above 60 consumes a lot, not only drugs, but also all other resources. Now, we will start with aging. So, aging, we all know, is a chronological age, biological age. So, aging is itself a process. Along with that aging, we also get into aging-related illnesses. This results in polypharmacy. Polypharmacy is a costly affair. It can cause more adverse drug reaction, hospitalization. It can cause more drug interactions and diagnostic difficulties and the increased cost of therapy. And the complaints also difficult when there's a polypharmacy. So these things one by one accumulate in a person as he ages. Aging is starting, age-related changes are occurring, age-related illness are coming, and then polypharmacy is added to that. So all these things interact together, and it becomes a very large affair for every individual patient on every consulting day. Now, main systems clinically involved, these 3 are mentioned actually. Central nervous system, cardiovascular system, and age-related cancers. So when a person is around 60 and above, you have to think about his CNS, whether he is optimal or suboptimal, and cardiovascular system, it may not be adequate to cope up with the daily requirements. And as age-related cancers will also set in when the age is increasing. If you analyze these 3, the cardiovascular system is obvious. Everyone is having hypertension, syndrome X, or any cardiac problem, or whatever it is, it's very obvious. The CNS impairment is very subtle and gradual, and that is less recognized. And if it comes, it is also confused with other types of morbidities like infarction or dementia, Alzheimer's, psychiatric illness, depression. All these things are coming. So this is the area which is maybe less in occurrence, but still very important for everyday life. So with these 3 in mind, cardiovascular system, central nervous system, and cancers, we will see next slide. This is the process of aging. When a person is aging after 40 to 50 years, his systems will start declining. And depending upon the genetic qualities and nutritional aspects and other social aspects, the rate of the decline of the systems may differ. On average, if you take a survey of different people, then we can see respiratory system is going down in a fast manner and so very down, very much down. The next middle level is the cardiovascular system declining, and kidney declining is there, but it is slightly later affair. So here we have declining is not that much common. It comes at a later part of life, and respiratory system compromising is not at all visually we can see in a clinical setup. They will end up with a
So please unmute yourselves.
So this slide is very important slide, which shows the decline, rate of decline and extent of decline of the three major organ systems. The breathing capacity is the first line, the cardiac index is the medial line, and the last line is the kidney function. So we can keep this in mind and accordingly plan. Whenever we see elderly person, we have to remember this cardiac index and renal function. Now, coming to basics of geriatric pharmacology, how to approach this topic. So we have to take up like this after the introduction and all, we have to go to pharmacokinetic changes and pharmacodynamic changes. Both together comprise geriatric pharmacology. Now, we first pharmacokinetic aspects. Absorption. Here, you know, antacids will impair absorption of many drugs. Laxatives will also affect the absorption, and diabetics will have slower gastric emptying time. So accordingly, based on that, we have to use drugs in a proper way. Next comes distribution. In elderly person, there will be reduced body water, reduced lean body mass, that means increased fat. This will affect distribution. We have to see these physiological changes and look into distribution of drugs. Reduced kidney weight, so kidney's function is less than the normal. Reduced hepatic blood flow, so drugs depend upon hepatic blood flow, metabolism will be affected. Reduced albumin and increased glycoprotein will affect the protein binding status of some drugs depending upon the albumin part or glycoprotein part. And reduced clearance is not obvious in all individuals. If you go by lab parameters of kidney function, we may not pick up the truth, because along with the fall kidney function, the compensatory mechanisms like lean body mass or less muscle in the body, all those will compensate and mask the reduced clearance. So we have to go by some special methods and then find out the clearance status and then plan for the drugs. So we have to remember these facts. Actually, when you apply clinically, when you read systemic pharmacology, these distribution aspects in some drugs, some points are important. We have to focus on them when you read those chapters. Metabolism, here we have a reduced speed of phase 1 reaction. So that we have to keep in mind. All drugs undergoing that phase 1 reaction will be having a reduced speed metabolism. Liver function will be altered due to aging or disease and drugs. Hereafter, we have to remember 3 points always. Aging itself is like a disease. There will be some changes in the body. Then it will have a disease also related to or not related to aging. That we have to keep in mind. And drugs are also like disease. They will go on the impact systems and they will have some effect on the body. So we have to keep all these three, and apart from liver function, we have to take into the consideration of the metabolic capacity of the individual. Elimination. So reduced renal clearance, we have to consider this formula, Cochrane formula, and when you use that formula, we have to adjust it for women and multiply by 0.85 and adjust the value for the women. And in general, always we have to start with a low dose and go gradually, wait for at least 3 half-lives before making change of any drug. And hydration status may hinder lab parameters. This is important. Whenever you interpret any lab parameter, like therapeutic drug monitoring, you have to interpret every lab parameter carefully. When was it taken? How was it taken? At what time? Before food, after food? When IV fluids were going on at that time? All these things you have to consider and then interpret any lab parameter. Coming to pharmacodynamic changes, the previous speaker was giving examples of 3 clinical cases which were more involved with the pharmacodynamic changes. Now we can identify them when we see one by one. So in elderly persons, all functions are declining. So this is one. So pharmacodynamics will also be correspondingly affected. Increased sensitivity. So they are more sensitive for some drugs like sedative hypnotic. So this is what happened. The haloperidol more sensitivity in combination with the domperidone visa, the metoclopramide. So we have to be careful. We have to remember this point. They are having more sensitivity. So they may react even for a small dose. So better to give small dose and then raise after some time. And third point is very important, reduced homeostasis. When anything is affected in a person, the compensatory phenomena is there. But in elderly, this will not be optimal. So the disturbance can be due to disease or age or drugs, whatever it is. This fellow cannot compensate and come out of the problem. So we have to keep in mind that this person is not having homeostasis properly. Similarly, you will have orthostatic hypotension. Because the blood pressure compensatory mechanisms are not optimal, they may go for orthostatic hypotension due to their own baroreceptor problem or due to drug-induced aspects. Then comes your cognitive deficiency. So mild forms and then moderate form and severe form. We can see cognitive deficiency. This will affect the therapeutics also. So they may not take drugs properly, or they may take too much of drugs like that. Then comorbidity, the diseases will affect the pharmacodynamics also. If the disease is in liver or in heart or in kidney, so that will also affect the pharmacodynamics of the current drug. Same thing with the polypharmacy. Other drugs given will affect the system and that will cause pharmacodynamic changes. Similarly, increased ADR. All these things put together will cause more and more ADR. So we have to be again prescribing for ADR also. This is the diagram which shows the x-axis is age. When age is going up, see the percentage of ADR is also going up, especially after around 60. You can see the tremendous rise in the incidence of ADR. What are the drugs commonly causing ADR? So NSAID may cause gastritis or kidney damage. Diuretics will start first with the muscle cramps, then they go into electrolyte imbalance, then some arrhythmias. Warfarin, ACE inhibitors, beta blockers. Beta blockers are very much known to cause a lot of ADR in elderly. Sedative hypnotic will cause exaggerated effect or a spillover effect on the next day. And anticholinergic effect will cause problems in your eye. Intraocular tension may rise or the bladder function may not be adequate. Will be actually retention will be there. So this fellow will have problem. So these commonly used drugs will cause this ADR. When we prescribe, we have to avoid or reduce the dose also. So NSAID, we have to give gastro-friendly NSAID. Diuretic, always remember new drug and the higher dose will immediately cause some muscle cramps. We have to be very careful. And they can cause also drug interaction along with the other drugs. And ACE inhibitor, warfarin are there. Beta blockers will cause definitely some blood pressure or heart rate or some other forgetfulness or lack of drive or memory function, something like that. CNS depression like phenomena will come at that age. So we have to monitor the dose of beta blocker. And sedative hypnotic, as we all know, they will directly cause more of sedation and hypnotic effect in the elderly person. And more of this we can see in some other slide later. And anticholinergic is not remembered by many people. This may cause increased intraocular tension or the urinary retention. So reduce the dose in renal disease and use anticholinergic drugs carefully. Why polypharmacy occurs? Apart from the multiple disease conditions, we will have also some patients demanding more drugs. For every symptom they say, we have to write a drug. This is the practice going on. For every symptom they say, you have to hear it and then write a drug. So this becomes like the prescription. And no regular review. They won't come for regular review. So there's no time for doctor to cut down the unwanted drugs. Similarly, they will consult different doctor for different purpose and there won't be any coordination and they will have a lot of drugs in their bag. So what to do? Other than this pharmacology and geriatric care, the elderly is also having a social problem, economical problem, and psychological issue. So about this, we are not going into detail, but a doctor, a family doctor has to remember that a person has other social, economical, psychological issue which will affect the treatment. For that purpose, we have to collect information about the social life about his economical status and about his psychological issues. For that purpose, we cannot just ignore them. Just collect the information and use it for your treatment purpose. So ADR and the elderly, 6 to 8 drugs commonly used. I told you the brown bag analysis means you have to ask the patient to bring all the drugs he is taking, his own drugs, self-medication, herbal medicine, OTC drugs, all the drugs, whatever he is taking, he has to bring in a bag and show to a doctor. And then we have to completely review the list of essential drugs required or not. Some ADRs are recognized, some ADRs are not recognized. So this we can note it down when we see the patient. This is a very important thing. Medication errors by doctors. When you treat elderly, there can be prescription errors. There can be drug interactions also. Nurses, they are this medication error just like that common in nurses. Patients, they will have the herbal medicine intake without telling the doctor. They will have OTC drugs for their own liking, and they will not adhere to the doctor's prescription, or they may have a over adherence also. They will keep on taking drugs which they like your alprazolam, or they may like to take liquid paraffin daily, and they will not stop any laxative even if you want them to stop. So these things will cause medication errors. And relatives also will be having the problem of wrong drug procurement to excess. They can create excess dosing, or they can miss some dose, and relatives may also cause a medication error. So now, considering all these things, what are the practical aspects of treatment? First thing, we have to give a lightly cheaper drug. We should keep the cost of drug in because already the long list of drugs. So we must prescribe and give a least costing drug. Compliance issue, we must consider whether he will take it properly for 1 decade or 2 decades. And that we have to see about insurance availability, which can support the economics. And the commonest problem is in elderly person forgetting to take the dose. And the problem will be leading on to repeat dose. If they forget, if they don't remember that they have taken atenolol, they will immediately take next tablet in 1 or 2 hours. And that will give a very cumulative hypotension. And if this happens with the diabetes prescription, they will go into hypoglycemia and rapidly to coma because 2 drugs are taken at the same time. So this is trying to underline this point. This forgetting is a natural aging phenomena, and forgetting to take the dose or not remembering that they have taken, but again taking repeating the drug, very, very common every day. Every family will have this problem. Stopping the drugs on their own when the symptoms disappear. So this is one thing. Whenever they are becoming better, they will stop the drug. Similarly, self-medication. They will go for self-medication, which can add up to the problems. So what can we do? For patients with the tremors, we can give dosing syringes because they cannot take liquid medicine or they cannot cut the tablet. We must go for dosing syringe. It's a better way. We should avoid tablets of larger size because they cannot swallow. So it's a very problem for some people. They cannot swallow larger size tablet. Then label should be very large in size. For elderly population, they cannot read the labels. So we must have a large size labels on the drugs. Written instructions on the drug intake will be better. You can put it in a cover and write the instruction whether twice daily or thrice daily, before or after food, like that. In a separate cover, label it properly in their own language and explain to them the mode of taking the drug and ensure that they have understood by asking them questions. So the communication is complete only by asking questions and ensuring that they have understood what you have told. Otherwise, there can be excess dosing also. Somebody will wrongly understand what you are telling and they will take 5 to 6 tablets together. Depending upon the drug, they will have some problem. So similarly, next is avoid changing names of. We should not change names of drugs very often because they will get confused. Similarly, strength of tablets also we should not often change. That's very important. And you should not change also the FDC combination. Already, whenever they are going for repeat prescription, the same type of formulation is not available for them. They will have a new types of supply from the market, and that will create a problem. So on the top of that, if you also make some changes unnecessarily, this will create more problem. So we have to take extra care whenever we see elderly person. above 55, when you see anybody, take detailed drug intake history without compromising on the type. Adopt rational drug therapy. All the right things should be taken. Keep goals for the treatment. Why are we giving a drug? What is the goal? Look for ADRs and drug interaction. In young population, okay, but in elderly person, that will cause more problem. So we must look for ADRs and drug interaction. Specifically, ask leading question and try to identify. They may not tell. Similarly, avoid medication errors at different levels, at doctor's level, at patient's level, relatives level, and nurses level. And here comes the caregiver. We have to educate caregiver also. If it is a modern medicine, for example, a lot of this insulin pen device or any hormone injection which has to be given through calibrated syringes. So we have to educate the caregivers. They can give the injection in a proper manner in hygienic precaution way. Spend more time with the patients in elderly persons. Simplify drug regimen. So the previous speaker was telling we have to audit the prescription and reduce the number of drugs. Use appropriate dosage form. Avoid sudden withdrawal of certain drugs. Premature discontinuation of drugs can lead to relapse of disease. And educate relatives on drug administration. Give counseling based on needs of the patient. So where is the lacuna? What is the patient asking? All those things we have to understand. Give time for patient to talk, and then we must know what he needs. Then on that aspect, we have to give him education. Then adjust with the patient disabilities and of hearing and vision. So these patients will not have a good hearing capacity, or they cannot see what you are writing. This we have to keep in mind and spend more time with them in a very patient manner, because he is elderly person and we are trained in geriatric care also. So we should always be very kind. It is maybe next to the kindness shown to mentally ill patients. So when you treat mentally ill patients, you must be very, very extremely kind to them. And this, next step, grade of kindness required for elderly persons. And treat comorbidities. Don't tell this is not my problem like that. At least we have to see what it is. Watch loading and maintenance dose. So some drugs should be given at a lower loading dose level or lower maintenance dose level. Give food intake instruction. Even if you don't give, they will ask, because they will know, they will have doubts about that. So for every drug, they will ask the food intake instruction. And focus on blood pressure changes. Morning, evening, different times of the day, in different posture. You can try to take blood pressure and see what it is. Give adequate pharmacy instruction. So whether a tablet, chewable tablet can be swallowed or swallowable tablet chewed, whatever it is, you should always adhere to the pharmacy instructions. The way drugs is prepared should be adhered to. You cannot do opposite methods. Dispersible tablet means dispersible. Chewable tablet means chewable. Not to be cut means not to be cut. So these things are very important. So for example, even our basic instruction we used to receive, shake well before use, suspension. Otherwise, only empty solid will be there. Active molecule will be in below the near the bottom of the bottle. So we should be careful. So give adequate pharmacy instructions. Elders have the right. Now this recent advance I want to include. In the clinical trials nowadays, the elders, they demand, they want to be under clinical trial. Because in other setup of therapeutics, they may not get the drug which are maybe costly or which have bad prognosis. So they want better drugs, even though are experimental, for want of the money or for want of better literature. So elders have right to be suitably included. And in some situation, we have come across cases that elders file on the court that they want to be in the clinical trial. This also we have to be keep in mind. Take holistic view of every elderly person's situation. We have to see social background, family background, economics, and take holistic view of every elderly person's situation. Otherwise, whatever you tell, you will tell, but they will not be able to follow. Plan to conduct suitable training programs for the elderly. This is the thing openly I just put. It's not medical aspect, any other aspect, and all other aspect of life have to be taught to a person as he grows up. But generally, if you take a non-medical person, their education is below the after the graduation, they will not undergo any training. But we are having a lot of training, our medical people. So we have to understand that they are not trained after that education of the college level. So they need training for all aspects of life, how to handle when they grow up. So this have included last sentence. But at least medical part of it, we can take care. Other part of it, we can leave it to sociology department. So this is the situation of elderly person. He is walking tightrope condition based on the tablets and capsules. So we have to help him to properly come out of this. What are the new challenges in this field? Drugs are becoming more expanding, and new nutraceuticals are coming every day, and anti-aging medicines are published every day, and new affordable medications are coming, and newer guidelines for clinical trials in different countries are evolving, especially for elderly persons, and immune boosters are now talked about all over the world in relation to corona. So these are all new challenges, and they have to take drugs for decades, not today or tomorrow or for 1 month. This we have to keep in mind. And the very important point is not adhering to non-pharmacological measures. Suppose you say the diabetic diet, they may not follow it very strictly. If you take exercise, they won't follow exercise. And if you say salt restriction, they will not be able to do it. When they don't do that, the therapy is not going to work at all. And sooner after some time, you will have complications. So we have to give them a special warning and special session to emphasize on non-pharmacological measures. Designing suitable boxes to hold the prescribed medicines according to the drug intake schedule. So here some people are using some special designed boxes in our country. They are available in some malls. We can go and purchase those boxes where you can classify the drugs and give to the patient. And this is a major issue in other countries. Even yesterday, we had some article where some such boxes were withdrawn by some major companies for some other issue. And again, the opposite people are trying to bring those boxes again into practice. So this is a major issue in other countries. In fact, I have read yesterday that they are packing the drugs depending upon the person individually and transporting the packed, labeled, arranged drugs back to the person. This free service is done by major companies. It seems they are withdrawing recently. So there's a controversy in other countries now. Just to emphasize, we have to know that we have to design in our house in a proper way, which we understand, and to avoid duplication of medicine. This is because they will take second dose, not knowing that they have taken the first dose. So design suitable boxes to hold the prescribed medicine according to the drug intake schedule. For that, you can understand here that we must give the minimum number of drugs, minimum number of tablets in a particular point of time, and try to bring together some drugs so that they can easily swallow. So after a breather of the revision of basic geriatric pharmacology, I will just put some slides for examples. Remember about out of this systemic pharmacology. So based on examples, we can look into other drugs also on our own. Aging, kidney, sensitivity of the person can cause more ADR to sedative hypnotic. So in here, sedative hypnotic means they will go for increased falls and fractures next day. So what are the better drugs among the sedative hypnotic? So lorazepam, oxazepam are better. Opioids. Opioids will show changes in respiratory system. So dosing should be made carefully. And actually in society, we are not giving opioids adequately for pain relief. So we should give the more care for respiratory system, and also we should not worry about using opioid. Whenever there is a pain in elderly person, we must be liberal in using opioids. And here you have to remember that opioid drugs are also can cause serotonin syndrome in a very common manner. So we have to be, especially tramadol, a tramadol dose and for type of formulation are available in different manner. So we have to start with the low dose, and a controlled release formulation may not give immediate benefit. And if you raise the dose and if you give it in a controlled release form, it can land up in a dumping syndrome and cause a severe problem. Or even ordinary dose for some individual may go into serotonin syndrome. And I have also seen recently that in some states, immunization supplies had tramadol, and some children got tramadol in place of paracetamol, and many babies died. And this has been recurring also. And for a long time, we never knew how tramadol goes into paracetamol place and why such things are happened. Then we can easily understand if we tell that there are combinations available between tramadol and paracetamol. They are meant for elderly or adult use. When these tablets happen to be taken at half the dose or quarter dose for a child or baby, easily tramadol can find its way into a baby. So you just imagine what will happen is opiate goes into a baby after immunization. So these are all medication errors which we can anticipate and take action to prevent. Dose of antipsychotics should be increased gradually. A previous speaker gave an example of haloperidol had some problem in the elderly person. And this antipsychotic can worsen memory also. And now what to do? Which antipsychotic you prefer? Thioridazine is a better choice from pharmacology point of view. Olanzapine is also a better antipsychotic drug. And dose of lithium for mania should be monitored carefully. And when you combine it with the thiazide, you should be more careful. SSRIs are better for depression in the elderly than other drugs which are there. For Alzheimer's, donepezil and rivaroxaban are better. For alternative, we can have memantine, but that is in another pathway that lacked on different pathway. For hypertension, thiazides are to be used in lower dose, otherwise there will be adverse effects. And when there is angina, atherosclerosis, CCBs are better. And when there is COPD, avoid beta blockers. And we can avoid ACE inhibitor when there is no diabetes or heart failure. We did not just like that prescribe ACE inhibitor for all patients. And beware of hypotension, cerebral ischemia, and falls. This drug therapy can induce hypotension, cerebral ischemia, or falls. Digoxin can produce arrhythmias, so we have to monitor renal function. Hypokalemia, hypoxemia, atherosclerosis, they all contribute to arrhythmias. And avoid disopromate based on pharmacokinetic aspects. And loading dose of lignocaine to be reduced in the elderly population. This is very important. We are not clinically aware of this because it's not highlighted in any. Reduced immunity, reduced mucociliary clearance, age, and diabetes, they make patients more prone to infections. So this is a combination. When there is age is there, diabetes is there, and the underlying reduced immunity is there, the clearance is not good in mucosa. So naturally, they will go for respiratory infection, pneumonia, and other septicemia, and multi-organ failure, and death. Just to see all these factors, what are the preventive, what are things you can prevent, what are the things you can take care to prevent the deterioration of the person. So, age you cannot alter, and diabetes, yeah, you can go for strict control. Reduced mucoclearance means we have to be aware of that, but we cannot do much about it. Reduced immunity means we can use some immune booster, vitamins, or any good diet as per the new recommendation. And we must safeguard ourselves from any infection situations. Otherwise, ordinary person just about 50 to 60 with a diabetes will unnecessarily get some infection and septicemia and die. So this is very important point. So urinary retention and catheterization can contribute to UTI. This in some situation this will cause these problems. So UTI will come because of those problems also. Use preventive vaccines liberally. So this is now situation elderly in corona. So preventive vaccine should be liberally used. Don't think because they are known to have a lower antibody level. And when you assess these antibody, you must keep in mind that cell immunity is also involved in corona vaccination. Don't look into antibodies alone. The CMA also has a role to play. In fact, that protects everyone, though you have a low antibody level. So keep this together in mind. An elderly person, corona, new viral infection, new vaccines every day. So we have to use vaccine liberally. There's no second thought about it. Vaccine ADR has very less when compared to the morbidity. You have to compare the probability and give a decision properly. And these antibiotics, they have contributed to prolongation of life. This is a new perspective I have come across recently. Of all the drugs in our system, in our medical aspect, antibiotics have contributed to prolongation of life. If you take survey and analyze so many diseases apart from infection, so many infections we have treated with antibiotic, and because the person has not died, how many lives we have saved because of antibiotic? So we have to understand importance of antibiotic. At the same time, use them carefully, especially aminoglycosides. NSAIDs, use them carefully. Aspirin can cause bleeding. New drugs can cause renal damage. So we must monitor renal function. Corticosteroids can cause osteoporosis. So before prescribing, consider whether to prescribe or not, and consider not compulsory that calcium, vitamin D and exercise should be prescribed. Wherever possible, avoid steroid. If you use steroid, consider whether you can give calcium, vitamin D and exercise to prevent osteoporosis. Thank you.
Thank you very much, sir. Such an elaborate and apt talk, I would say. Your experience was really shared with all of us. We all enjoyed. And a real thanks to be with us physically, our Director, Institute of Pharmacology, Madras Medical College. Till now, I'm not feeling that sir is not in KMC. We always feel you that you belong to KMC, sir. We would love to thank you from all the persons of KMC being with us and being a speaker and delivered a great lecture on this occasion. Thank you so much, sir.
I now request Bhatt sir to accept a memento from our HOD Aruna ma'am as a token of gratitude and appreciation. Thank you, ma'am. Thank you, sir. Thank you, ma'am. Thank you, sir. Now I'd like to hand over the session to Dr. Kirtana for the quiz.
So now, like, everyone can be ready. The quiz will start in just a minute. You'll be given 30 seconds to answer these questions. You can just answer in the same screen as you are just seeing. The first question is going to be on screen.
Shall I launch the question?
Yes, Sahiti, launch.
Okay.
All of you are ready for the quiz?
I will give a reminder.
Hope all of you are ready. The first question is on the screen. 30 seconds for each question.
Ten seconds more.
Second question is in the display. Please answer.
Third question. Last 10 seconds. Question.
The fourth question is in the screen. Please answer.
Last 10 seconds. Fifth question. Last 10 seconds. Sixth question. Last 10 seconds. Seventh question. Last 10 seconds. Eighth question. Okay. 10 seconds more. Ninth question. Ten seconds more. Tenth question and the last one. Ten seconds more. Time up. Thank you, everyone.
I think you were able to answer for all the questions. We'll see who wins the prize. The next set of questions will be after next two sessions. Over to the obstetrics pharmacology. I now request Dr. Aisha ma'am to give an introduction about our next speaker.
Hope you all had a very good time with the quiz. We have already planned 2 more quiz sessions, one after the 2 speakers talk about obstetric pharmacology. Again, you will have 10 questions you have to answer. First consideration will be the correct answer. Number of more correct answers will be considered as the first, second, and third. If we have a tie, then we'll have the time, fast finger first. That will be considered. So this will be an interesting part for all the postgraduates who are connected with us and also the faculty, I believe. We have 4 more talks, 2 on the obstetric pharmacology and in the afternoon session, 2 on the pediatric pharmacology. Hope we are going in the correct track about today's pharmacotherapy, which is more focused on precision medicine, that is individualization of medicine. We are so much focusing pharmacology. We are not stopping short with just knowing the classification of drugs, which we are supposed to know. So the present day medicos, whether you are a clinician or a pharmacologist, you must be aware what way the pharmacotherapy is focusing nowadays. So it is expanding towards individualization of medicine. That's why we have thought of this topic today, how to individualize, though it is not much to be a precision medicine, individualization of medicine, to some extent about the special situations, phases of life. So that is what is focused on today's program. So we are going to the next session. I would like to call Dr. Aisha to introduce the prestigious obstetrician who works in the London Hospital, Kuwait. She is going to be connected from there in Kuwait, Dr. Soviet Selvi. I call Dr. Aisha to introduce Dr. Soviet Selvi.
Thank you, ma'am. So our third speaker of the day, Dr. P. Soviet Selvi, is a specialist with over 24 years of experience in the field of obstetrics and gynecology. She's working in the London Hospital, Kuwait. She graduated from Stanley Medical College and completed her post-graduation in obstetrics and gynecology from CMC Vellore. Madam is an expert in handling high-risk pregnancies, cesarean sections, and gynecological procedures. We welcome you, Madam, to enlighten us with your experience in a clinician's perspective of obstetric pharmacology. Over to you, ma'am. She has been the best performer to 2019, and she has also been awarded Best Employee Award 2004, and she has been awarded Doctor of Excellence 2020. Over to you, ma'am. Thank you.
Hello. Can you hear me? Am I audible?
Yes, Soviet, you're audible. You can proceed.
Okay. Thank you, Dr. Aisha, for such a kind introduction about me. Respected organizers, Dr. Arina, Professor Head of the Pharmacology Department, faculty members, eminent speakers, and my dear students. A very good morning to you all. Can you see me? Hello?
Yes, ma'am. Yes, ma'am.
You can see, right? Okay, thank you so much. I'm Dr. Soviet, working as a specialist obs and gynae in London Hospital at Kuwait. And indeed, it's a great honor for me to be part of this webinar. Thank you so much for this opportunity. Our hospital protocol is based on clinical guidance from obstetrics, Royal College of Obstetrics and Gynecology, UK. So all the slides will be based on the management, what I do in my hospital. And without wasting much time, let's go on to the slides. This is our team. So let me just speak on the common drugs, what we use in the routine antenatal care. Folic acid, you all know, we start in the first trimester. And in fact, ideally, it should be started 1 month prior to conception, and it needs to be continued for the first 3 months. The dosage is about 400 mcg. And in the second trimester, the requirement will be around 600 mcg. And during lactation, it's about 500 mcg. And the effect of folic acid, we all know it prevents neural tube defects, cleft lip, cleft palate, low birth weight, and prematurity. And the next one is iron supplements. We make sure that the elemental iron is about 30 to 60 mg. And as per WHO, we all know the definition of anemia is less than 11 grams. And as per the CDC, it is 10.5. And in postpartum, less than 10 grams, we consider as woman as anemic. And we make sure the patient continues iron supplements and folic acid and vitamin D, and the calcium about 1000 milligram. As we know, the calcium requirement is about 1.5 to 2 grams of elemental calcium per day, and it helps in prevention of gestational hypertension and preeclampsia. Next, let's move on to the complicated pregnancy. Whatever the management I'm speaking, this is what we do here, and it is based on Royal College protocol. Mild preeclampsia, if the patient is removed from term, that is blood pressure 140/90 and above, 1 plus protein. We start them on alpha-methyl-dopa. It's one of the well-tested and safest antihypertensive drug. Dosage, we start with 500 mg and we can go up to 2 grams per day. And the next drug which is available here in Kuwait is labetalol, which comes as 100 mg tablets. We just start at 3 times a day, and maximum dose we can just go up to 2,400. And the other drug what we commonly use is nifedipine, which we start 10 mg 8 hourly, and then we increase if required 20 mg 8 hourly. All the antihypertensive drugs, what it does is it prolongs the pregnancy and to get the fetal lung maturity to avoid neonatal ICU care like RDS, NEC, and sepsis. Steroids goes hand in hand with antihypertensive therapy if the woman is from 24 weeks to 33 weeks. What we use here is dexamethasone 10 mg IM at 2 doses at 12 hours apart. And the other drug which we use also is betamethasone, which is 12 mg IM, 2 doses at 24 hours apart. In severe preeclampsia, when the blood pressure is 160 by 110 and above, and proteinuria 3+, if the urine output less than 500 ml, pulmonary edema associated with cerebral and visual disturbances, our treatment will be prevention of convulsion, control of blood pressure, and the definitive treatment is delivery, either by vaginal or cesarean section, depending on maternal and fetal conditions. The anticonvulsant treatment, what we routinely use in London Hospital is magnesium sulfate. That is a drug of choice here. And we give loading dose 4 milligram, that is 20 ml of 20% IV over 4 minutes. And as we all know, magnesium sulfate is indicated for severe preeclampsia and eclampsia. And immediately followed by a maintenance dose, 10 mg, that is 20 ml of 50% intramuscular, 5 grams in each buttocks. And if convulsion persists after 15 minutes, we give 2 grams IV over 2 minutes. And the maintenance dose is about 5 grams intramuscular every 4 hours and alternate buttocks. The therapeutic level of magnesium, we just to make sure it is around 4 to 8 mg per dl. And when we are giving magnesium sulfate, we check for peculiar reflex, urine output, making sure it is more than 30 ml per hour and respiratory rate more than 12 per minute. And there is magnesium toxicity. The antidote what we use is calcium gluconate slow IV, and also we give some oxygen, nasal oxygen. And we continue magnesium 24 hours postpartum, post-delivery. In severe preeclampsia and eclampsia, we use idolizine commonly here, which is given as 5 to 10 mg IV bolus in the beginning, and we monitor blood pressure every 5 minutes. Goal is to bring down the diastolic BP less than 100 mg. The mode of delivery here, if it's favorable cervix, use prostaglandin gel, unfavorable cervix and preterm mothers, we do cesarean section. The commonest anesthesia analgesia is regional, either epidural or spinal. The next, let's go to diabetes management. Patients, if they are diabetic, preferably they should come for a preconceptual counseling. We make sure the HbA1c comes down to less than 6.5. And if the patient is obese, we counsel on weight reduction, and we put the patients on folic acid, preconceptual folic acid 5 mg per day till 12 weeks. Gestational diabetes, mainly we focus on diet, and we have a dietitian, so who guides the diet part, and we also encourage our patients to go on exercise. And olden days, we used to start insulin. Nowadays, we start on oral glucose lowering agent like metformin, which is very commonly used like paracetamol, and it's quite safe for the mother and the baby. And if necessary, we add on insulin. OGTT is considered to be abnormal if fasting blood sugar is more than 5.6 and second are more than 7.8 millimole and above. Treatment, we start with metformin, and if the blood sugar is not coming under control, we go up metformin 1 gram twice a day. If blood sugar is not under control, not optimum, we just put them on short-acting analogs like aspartate and lispro, which comes as an NovoRapid here. Or we supplement also long-acting insulin like ISF and NPH insulin once a day in the night. That is NovoRapid 3 times a day. If not coming under control, we add Livermere at bedtime. The optimum control for the blood sugar is fasting less than 5.3 and first are 7.8 and second are 6.4 millimoles. What it does, all this oral anti-diabetic drugs and insulin, it reduces the chance of macrosomia, reduces maternal and fetal trauma, reduces the incidence of cesarean section, neonatal hypoglycemia, hypocalcemia, and perinatal deaths. Intrapartum management, in diabetics, we usually keep them on a sliding scale. 50 units of Actrabid in 50 ml of normal saline, that is soluble insulin, and we start with 1 unit per hour, and we titrate according to the blood sugar levels. The expected blood sugar level in intrapartum is about 4 to 7 millimoles. Postpartum management of GDM and diabetes. Diabetic mothers, the requirement of insulin comes down as all the diabetogenic hormones are reduced after delivery. And GDM, there won't be any indication for medication, but they have to be careful. They have to take care of their lifestyle modification and weight management. And type 2 diabetic mothers, we advise the patients to continue if she's on metformin because it's safe in breastfeeding. Another problem what we see in pregnancy, the commonest problem is UTI. We all know that it causes preterm birth, low birth weight, maternal and neonatal sepsis, the commonest organism being E. coli. The drug of choice, normally we start on nitrofurantoin 100 mg 3 times a day for 5 days. The other drugs which are safe in pregnancy are ampicillin and cephalosporins. And we do a repeat culture after 7 days of completion of antibiotics. In case if there is a recurrence, we repeat another course of antibiotics for 10 days. If there is a recurrence, we need to rule out calculus and renal tract anomaly. If more than 2 episodes, we start them on low dose antibiotics, nitrofurantoin 100 mg at night, or ampicillin 250 mg once a day, or cefalexin 250 mg OD. All these drugs are safe in pregnancy, and we continue till 4 weeks postpartum. Another infection, what we come across is group B streptococcus. We all know that it causes maternal sepsis, preterm labor, and neonatal sepsis and pneumonia, which is quite dreadful. So according to CDC, we do a universal screening. We do a high vaginal swab at around 35 to 37 weeks. And we give intrapartum antibiotic prophylaxis, ampicillin 2 grams IV stat and 1 gram IV 4 to 6 hourly till delivery. In case of penicillin allergy, we give erythromycin or vancomycin. Another common problem among these Arab ladies, they come with a lot of vaginal discharge. The commonest thing is bacterial resinosis, which we all know that it causes preterm labor, chorioamnitis, and postpartum endometritis. We manage by giving metronidazole 500 mg BD for 7 days or clindamycin 300 BD for 7 days. Both these drugs are safe in pregnancy. And another problem we face is threatened miscarriage, that is early pregnancy with bleeding. We start them on micronized progesterone suppositories. And we also give this oral defestone, that is dry hydrogestone, 10 mg 3 times a day for 12 weeks. And progesterone is given also as a pervaginal form, 400 mg PB twice a day till 16 weeks. In case of recurrent miscarriage, suppose if it is antiphospholipid antibody syndrome, we start them on low dose aspirin, 75 to 100 mg daily, and continue till 36 weeks, and low molecular weight heparin, enoxaparin 0.4 ml subcut daily. And we continue till term, and we stop 2 days, 48 hours before, and then plan for induction or cesarean section. In case of activated protein C resistance and thrombophilias, we give low dose heparin, enoxaparin 0.4 ml subcut daily. Management of preterm labor, what we routinely use here is nifedipine. Nifedipine tocolysis is quite safe and quite effective also. Nifedipine we start at 20 mg stat, and we repeat if contraction persists. 10 mg once in 20 minutes for 2 doses, and maintenance dose 20 mg 8 hourly for 24 hours. Other drug which is quite expensive here, I don't know whether how is it in India. Atosibin, this is oxytocin receptor antagonist, most preferred tocolytic with lesser side effects like chest pain, palpitation, tachycardia, nausea, vomiting, headache, and hypertension. This is freely available here, and the dosage is about 0.9 ml IV bolus over 1 minute, and we keep them on maintenance dose 24 ml per hour over 3 hours, and then continue with 8 ml per hour for about 45 hours. If retreatment needed, we reduce the dose, bolus 6.75 mg and then 37.5 mg per 5 ml infusion. Contraindication for tocolysis is if patient is less than 24 weeks pregnant or more than 33 weeks. It is contraindicated in PROMs, antepartum hemorrhage, intrauterine fetal death, placenta previa abruptio, and fetal distress. Other tocolytics, beta symptomomatics, magnesium sulfate, NSAID like indomethacin. In preterm labor, maternal corticosteroid plays a major role. Same thing in dexamethasone or betamethasone we commonly use. And in case if we suspect any infections, we give antibiotics, ampicillin 2 grams IV 8 hourly, and flagyl 500 mg IV 8 hourly till delivery. In case of cesarean section, we use 1 dose antibiotic prophylaxis, single dose of injection ceftriaxone 1 gram IV, and injection flagyl 500 mg IV after clamping the cord. And to control the bleeding, we routinely use carbitocin, that is Farbal, 100 mcg, that is 0.1 mg, single dose flow IV over 1 minute for controlling the PPH. And also as a prophylaxis we use. And all the patients after cesarean, we put them on a thromboprophylaxis. We don't want DVT in post-op period, so we just give injection flaxine, 0.4 ml subcut OD. And we start after 12 hours of surgery, and we continue for about 7 days. The dose for flaxine is about 0.5 mg per kg. How we manage postpartum hemorrhage? First of all, we have to rule out if there is any trauma, laceration, extensions, retained products, which should be managed surgically. The medical management, we use ergometrin 0.5 mg IM/IV, Syntocinon 10 units IV bolus, and subsequently we give 40 units IV infusion. And carbetocin, that is Farbol 0.1 mg IV over 1 minute, and we repeat after 15 minutes. The maximum 3 doses can be given. Misoprostol is banned here, but I've used this in India when I was practicing in India, and it's a very effective drug. Labor induction, next, we normally use prostaglandin. It's a very effective one. And prostaglandin gel, dinoprostanol gel 0.5 mg, 6 hourly, we use up to 3 doses. And oral prostaglandin tablets also we use. And in case of PROM, we use here Cervidil, that is controlled release pessary, 10 mg over 24 hours. Once the patient started having contractions with the cervix dilatation more than 4 centimeters, we remove the pessary and we wait for 1 hour and then start the oxytocin. Oxytocin is used here only when the cervix is favorable in the form of 1 to 2 milli international per minute and increase at 30 minutes interval. As I told, misoprostol is banned in the Middle East, and I've used it in India, and it's quite an effective drug. Only thing we have to be careful about the hyperstimulation, and patients with the previous cesarean section, we cannot use misoprostol. This is me in action. This is a team of doctors. Supposed to be Kuwait Towers, which is one of the beautiful monument to show their modern Kuwait. Thank you for your time, and thank you all.
Thank you, Dr. Soviet Selvi.
Thank you for this opportunity, Arna. Thank you for patient listening.
You have to stop sharing your screen.
Okay. Stop sharing the screen.
Yes, I immensely thank Dr. Soviet Selvi
1 minute, Aruna.
for being a speaker, and it was a very good sharing of clinical experience, a crispy presentation which addresses the clinician's view on the use of drugs during obstetric and gynecological practice, especially obstetric practice. We thank you for this wonderful crispy presentation, Dr. Soviet Selvi. I would like to put some questions. If any participant have any queries to be raised to Dr. Soviet Selvi, please share in the chat box. I think we have a question already. Can you throw light into the usage of heparin and warfarin during pregnancy? Dr. Soviet, please.
We use only heparin, Arna, low molecular weight heparin, enoxaparin, which is quite safe. And we use it as 0.4 ml subcut OD generally. And obese patients, we calculate according to the body weight.
Soviet Selvi, are you able to hear?
Yeah, I can hear, Arna.
Yeah, you please unmute and answer for this question. Can you throw light into the usage of heparin and warfarin during pregnancy?
Actually, warfarin we don't use in the first trimester, though I don't use warfarin in my practice. Hello? Can you hear me?
Yeah, you're audible.
Yeah. See, warfarin is contraindicated in the first trimester, and it can be used in the second trimester. But we have to monitor the clotting time and other things. So normally we use only heparin. Hello?
Yes, you are audible. Thank you. Thank you for your
update.
Yeah,
I use only low molecular weight heparin, which doesn't require all this, kind of clotting, bleeding factors, monitoring and all. It doesn't require.
Maintenance, monitoring.
Yeah, it is quite easy for the patient. So,
any more questions from the participants? You can share in the chat. If there are no more questions, I would like to once again thank Dr. Soviet Selvi for being with us on this webinar. Thank you so much. I'll be presenting the memento to you at a later date.
Thank you so much. Thank you so much for this honor. Aruna.
Thank you. Thank you. I would like to call upon Dr. Anuradha to introduce the next speaker, Dr. Kurandi Ammal. Dr. Anuradha.
Good morning, everyone. It's given me the immense pleasure and happiness and pride to introduce the next speaker, my teacher, Dr. M. Kulandi Ammal ma'am, professor and head of the Department of Pharmacology, Stanley Medical College. She graduated from Keelpark Medical College and completed her post-graduation in obstetric and gynecology and pharmacology from Stanley Medical College. As the coordinator of Medical Education Unit in Chengalpet Medical College and organized many skill training workshops and CME program for undergraduates and postgraduates. Madam is at present the member secretary of IEC and resource faculty for the RBCWO Medical Education Unit, Stanley Medical College. She has always been interested in students' welfare and has been their strong pillar of support. She has always been in the forefront of academic activities by organizing workshops, conferences, and organizing quiz program. We welcome you, ma'am, to share with us your valuable points about the pharmacologist's perspective of the obstetric pharmacology. We welcome you, ma'am.
Thank you, Dr. Anuradha, for the nice introduction. Anevarukkum vanakkam. I thank the Almighty. His blessings has made me a professor. I wholeheartedly thank the organizers and Professor Dr. Aruna, HOD, Department of Pharmacology, Keelpark Medical College, for giving me this opportunity to deliver a lecture in my alma mater. I graduated from this college in the year 1989. So it's a real privilege to be a part of this program. Thank you, madam. So we will get into the slides. Yes, ma'am. Yeah, we can start. Okay. So we'll be discussing on the above heads. So pregnancy is associated with many physiological changes that can influence drug absorption, distribution, metabolism, and excretion. So understanding the physiological and pharmacokinetic changes in pregnancy and the gestation-specific pharmacology of different drugs is necessary to limit maternal and fetal risks. So according to the surveys, it is seen that nearly 2/3 of all pregnant women take at least one drug during their pregnancy apart from the regular iron and vitamins, maybe antimicrobials, etc. So drugs used in pregnancy is a public concern. So the need to treat the mother must balance the adverse effect to the fetus. So drugs are a definite requirement in any clinical situations like diabetes, hypertension, preeclampsia, or any chronic conditions as like epilepsy, immunology disorders, organ transplants, and any acute condition. So all these is mandatory. They have to take the drugs. So drug treatment presents a special concern when it is teratogenic. So imagine the historical evidence, thalidomide crisis in 1960 and use of still best pro. So evidence-based decisions on drug selection, safety, frequency, and therapeutic monitoring to ensure the safety is not very well explained so far. So the FDA had given categories for drug from A, B, C, D to X, but this category is next slide. So next slide. So this category has become questionable because evidence on teratogenic risk gets accumulated and the categories needs to be changed time to time. So the conventional method was replaced by pregnancy and lactation labeling rules. So the drug label, according to this was established in 2016 by the FDA. So the drug label should contain more information about the risk of taking the drug, every drug during pregnancy. So this label should contain the risk of taking the drug during pregnancy and breastfeeding, the evidence that has identified these risks, and the information should be the clear information to the healthcare practitioners to decide whether the drug can be used during pregnancy. And the risk and benefit of using the drug in the pregnancy should be given. Next. So this is taken from the FDA. So this drug labeling replaces letters with narratives instead of A, B, C, D, replaces letters with narrative addressing potential changes that occur in a maternal fetal placental unit during pregnancy, influences the metabolism, absorption, distribution, metabolism, elimination. So before getting into it, first we will know a little bit about the feto-placental unit. Placenta is the functional unit between the fetus and the fetal blood and the maternal blood. So the fetal blood vessels are contained in the villi of the placenta that extend into the walls of the uterus. So a mother's blood passes through the intervillous spaces. Next. This placental membrane separates a mother's blood in the a very thin placental membrane separates the mother's blood in the intervillous spaces from the fetal blood inside the villi. So drugs from the mother crosses this placental membrane into the blood vessels in the villi, pass through the umbilical cord and then into the fetus. Next. So how drugs are going to affect the fetus depends upon the fetal stage of development. Maybe 3rd to 8th week after fertilization, there is a period of organogenesis. So if the drug goes during this period, miscarriage and birth defects can occur, a very dangerous period of teratogenicity. So after the 9th week, there is alteration in the growth and function of the normally formed. The organs will be formed and the tissues will be formed. So the drugs will alter the growth and function of the normally formed tissues. So the fetal stage of development is very important. The strength and the dose of the drug, permeability of the placenta, genetic makeup of the mother, that is very important. And general condition, whether she has got any diseased mother. So the general condition of the mother, all these factors are important. So a fundamental concept in pharmacology is that a drug must reach the target tissue at sufficient concentration to exert its therapeutic effect. We should know what are the changes that are occurring in the physiological changes that are occurring in the maternal cardiovascular system. So there is an increase in the ventricular wall mass, increased myocardial contractility, increased compliance. So in the first trimester, the heart rate and stroke volume are increased. Increase in the cardiac, this will increase the cardiac output by 50% in the first trimester. From 28 to 32 weeks, it will plateau and will be maintained throughout pregnancy. So because of this increase in the cardiac output, there is an increase in the renal and the uterine blood flow. But minimal alteration in liver and cerebral blood flow. So there is an increase in the cardiac output. Then the vasodilatory effect of progesterone, nitric oxide and prostaglandin will decrease the systemic vascular resistance. So the BP will be decreased. Physiological hypertension can occurs in 20 to 24 weeks of pregnancy. Near term, it rises and becomes normalized. So this should be in mind. There should be a caution when there is a pre-existing hypertension or already when the woman is on antihypertensives. Next. So this is the maternal physiological changes pertaining to cardiovascular system. Increased cardiac output, increased glomerular filtration rate, increased renal blood flow, increase in the uterine blood flow. Next. So changes in the maternal respiratory system. So there is an increased progesterone. This increased progesterone will increase the tidal volume. So there will be an increase in the minute volume, which is the product of tidal volume into respiratory rate. So the increase in the PaO2 and there is a decrease in the PaCO2. So this will cause carbon dioxide diffuse freely from the fetus through the placenta into the mother. So which will be eliminated by the mother's lungs. Next. And there is an upward pushing of the diaphragm. This will decrease the functional residual capacity and this will decrease the total lung capacity. So this decrease in the FRC will lead on to hypoxemia. So you should be careful while inducing with general anesthetics. Then there is an increase in estrogen. This will increase the vascularity and the edema of the upper respiratory muscles. There can be rhinitis and epistaxis also can occur during pregnancy. At the same time, sometimes the Indian drugs, because of this increased vascularity, the Indian drugs like steroids will be readily absorbed. Changes in the maternal renal system is there is an increased urine formation due to increased fluid intake and the load of the excretory products of the fetus. There is an increased glomerular filtration rate. The increase in the steroid hormone estrogen and aldosterone during pregnancy causes renal tubular reabsorption capacity of increasing the sodium and water. There is increase in sodium, water and sodium retention. The increase in nitric oxide and relaxin causes renal vasodilatation. Renal blood flow will be increased and the GFR will be increased by 50%. So this is important for drugs which are eliminated by the kidney. Example, lithium, ampicillin, increased elimination rate. And like for drugs like lithium, ampicillin, digoxin. And there is an increase in the total body water, increased fluid volume of expansion, and this will decrease the peak serum concentration of hydrophilic drugs because they will move fast. Changes in the gastrointestinal system. There will be delayed gastric emptying because of the increased progesterone, and there will be a prolonged bowel transit time. This will delay the absorption of drugs. Next. Increased gastric pressure, compression of the gravid uterus, reduced muscle tone of the lower esophageal sphincter will lead on to gastroesophageal reflux disease. So these are the physiological changes which are occurring in the system. Next, we'll go to the pharmacokinetic changes in pregnancy. So first we'll go to absorption. Because there will be heavy nausea and vomiting, there will be decreased amount of drug available for absorption following oral administration. So the drug should be given when there is a vomiting free period only. Then decrease gastric acid production and increase mucus secretion. This will increase the gastric pH. So there will be an alkaline pH. So when there is an alkaline pH, according to the Henderson-Haselbalch's equation, when the pH is alkaline, there will be ionization of the weak acidic drugs. There is decreased absorption of acidic drugs like aspirin. Whereas there will be unionization of the weak basic drugs, there will be increased absorption of drugs, alkaline drugs like caffeine. Then increased progesterone in pregnancy leads to reduced intestinal motility and decreased gastric emptying, as already known. So that will alter the drug absorption. The bioavailability of the drug will be reduced. There will be a decrease in the Cmax and the increase in the Tmax. Onset of the action is delayed. The increase in cardiac output and increase in intestinal blood flow also will increase the drug absorption. Increase in pulmonary blood flow and the increase in respiratory rate will cause increased uptake of volatile anesthetic, so the dose requirement should be reduced. So coming to, that is about absorption. Then coming to drug distribution, the volume increase in the heart rate and stroke volume, we know there is an increase in the cardiac output. Cardiac output increases the uterine blood flow, 17% compared to 2% pre-pregnancy rate. Next. There is an increase in the renal blood flow, there is an increase in the plasma volume, and there is a total body water. All body fluid compartments will be increased. So what happens? The hydrophilic drugs the volume of distribution will be very high. So once there is a large volume of distribution, the plasma concentration of these hydrophilic drugs will be lowered. At the same time, maternal body fat also expand. So this will increase the volume of distribution of lipophilic drugs. Next. So these are the changes. Total body weight increases, total fat mass increases, body water increases, plasma volume increases. Next. And then there is what are the changes occurring in the protein binding? There is a reduced concentration of albumin and alpha-1 acid glycoprotein in a pregnant woman. So this will reduce the plasma protein binding during pregnancy. That is 13% at 32 weeks of pregnancy. So this decreased protein binding will lead on to higher concentration of the free drug. This higher concentration of the free drug will cause more distribution to the tissues. Like this is dangerous for drugs like phenytoin. The toxicity increases due to increased unbound concentration. Next. So maintaining the plasma, when we are trying to maintain the plasma concentration in the therapeutic range, there will be increased free drugs and there will be increased drug toxicity. So monitor the free drug concentration, adjust the dosing, and maintain the unbound concentration within the therapeutic range. Only the unbound concentration should be maintained in the therapeutic range. So low protein binding, increased free drug, more distribution to the tissues. So the plasma concentration in the therapeutic range can lead to increased free drug, which is toxic. So you have to maintain the concentration of the unbound. So this is about the distribution. Now coming to drug metabolism. Chemical modification of a drug to specialized enzymes. This is metabolism. So mainly the liver is the major system. Intestine and placenta, skin may play also a role. Next. What happens in pregnancy? The hepatic blood flow decreases in proportion to the total. There is an increase in the total cardiac output, but the hepatic blood flow doesn't change. So there is a proportionate decrease in the hepatic blood flow. This decrease in the metabolism, this will decrease the metabolism of high extraction ratio drugs. Extraction ratio is the elimination of the drug when it gets into the liver. So when there are drugs with a high extraction ratio, there will be decrease in metabolism for drugs like morphine and propranolol. Same time, this decrease in blood flow will slower the offset of anesthetic drugs, skeletal muscle relaxants like vecuronium, rocuronium, etc. So it takes about 15 to 17 minutes to wear off in pregnant women. So we have to be careful in pregnancy when we are going to administer these drugs. Then hepatic drug metabolism. Hepatic drug metabolism is dependent upon the cytochrome P450 enzymes. So in phase 1 microsomal enzymes, there is decreased activity of CYP1A2 and CYP2C19. CYP2C19 is decreased, CYP1A2 is decreased. So this CYP2C19 metabolizes omeprazole, clopidogrel, etc. So there is this decrease in activity will influence the efficacy of these drugs. And there is increased activity of CYP3A4, CYP2A6, CYP2D6, and CYP2C19. So this will be increase the metabolism of drugs like phenytoin, phenobarbital. The phase 2 enzyme, most important here is the uridine 5-diphosphate glucuronide transferase enzyme, which is increased in pregnancy. So the substrates of this enzyme, like bromotrigon, when they are given in pregnancy, there will be low concentration of these drugs. So poor seizure control. So necessitates dose titration of these drugs, which are all substrates for this UGT1A4. So this is about metabolism. It's a decrease in the protein binding and the increase in the fluid volume, and there is alteration in the metabolic enzymes. So what is drug elimination? So drug elimination is in the 3rd trimester, we have a high cardiac output. There is an increase in the renal blood flow. There is an increase in the GFR by 50%. So drugs which are solely excreted by glomerular filtration, example, cefazolin, clindamycin, etc. There is increased elimination, lower steady state concentration. but this is not strict. There are variation in drug clearance that limits the generalization of drug clearance. For example, if you see that clearance of doubles for lithium increases by 30% for digoxin. Digoxin is normally excreted by the kidney, and 12% for ethanol. So we cannot fix it up. We cannot fix up this clearance. So this is about the kinetics, that is absorption, distribution, metabolism, and excretory changes which are affecting the drugs in the pregnant women. Now, the drug has to pass through the placenta. What are the events which are going to happen? It is dependent upon the lipid solubility of the drug. Lipophilic drugs will be freely diffused across the placenta. Example, thiopentol, which is used in cesarean section, it will easily cross the placenta. Degree of ionization. Again, unionized drug, the penetration of the unionized drug is very rapid. Highly ionized drug will be retarded, like succinylcholine 2, tubocurarine, or highly ionizable, very low concentration in the fetus. Next. Molecular size is very logic. So more than 50,000, very poor. So heparin, an anticoagulant, because of its high molecular weight, is unable to cross the placenta. So it is safely used in pregnant women who need anticoagulation. Whereas oral warfarin is highly teratogenic. So we need to use only heparin. Then placental transporters. These are very important. These are transporters. There is a P-glycoprotein encoded by the MDR1 gene expressed in apical microvillus surface. They protect the fetus by excluding harmful, that is the main purpose, excluding harmful xenobiotics. So P-glycoprotein will pump back anti-cancer drugs like vinblastine or toxophilin. At the same time, it will pump back viral protease inhibitors. So what will happen? There is increased chance of vertical infection of HIV from the mother to the fetus when these drugs are given in pregnancy. SSRIs, pregnant women go for depression. So the need to give SSRIs is important. So SSRIs will inhibit this P-glycoprotein. So this decreased, and at the same time, towards the late gestation, the P-glycoprotein expression is also decreasing. So we have to monitor the drug in SSRI. We have to minimize the dose because that will lead on to fetal consequences. The another protein is the breast cancer resistant protein. Substrates or antibiotics, antiretroviral drugs, and calcium channel blockers. This is identified on the basal side of the fetal blood vessels. Next. Placenta itself is a site of metabolism. Hydrolysis, N-acetylation, and metabolism can lead to toxicity of many drugs like ethanol. Importance is placenta has the ability to convert prednisolone to inactive prednisolone. Hence, prednisolone can be used in pregnancy, requiring corticosteroid treatment like in preterm. So this is the fetal drug metabolism. Drugs enter from the mother, enters the placenta. It will enter the fetal vein in the umbilical cord. 60% will enter the umbilical vein, enter into the liver, and then partly metabolize. The remaining drug will go to the fetal arteries. 40% will enter the general circulation and go directly into the fetal arteries. So this plus these free metabolized drugs, the fetal arteries, there will be an increase in the large proportion of drug will re-enter the placenta. So increasing the concentration of the drug is highly deleterious to the fetus, causing toxicity. So it is mandatory that you have to monitor the drug dosage and drug levels in pregnancy. So with the pharmacokinetics, we will go on to the pharmacodynamics. What the drug does. That is, perinatal pharmacology is an emerging area. So involves drug administration to the pregnant women with the fetus as the target. That is main. Like corticosteroids, we are using it for fetal lung maturation when premature labor is expected. Then anti-arrhythmic drug, when there is a fetal cardiac arrhythmia, we do give advances. Fetal anti-arrhythmic drugs are given to the mother. Then maternal zidovudine for preventing transmission to the fetus. Next. At the same time, most important thing is the damage caused by the medication. Main is teratogenicity. What is teratogenicity? The ability of the drug to cause fetal abnormalities and deformities. That is teratogenicity. The teratogenic period is, as I said earlier, 6 to 8 weeks post-conception, 31 to 71 days. At the same time, there is adverse fetal effects. That is dysfunction of an organ or tissue. This occurs late in pregnancy. Already the organs are formed. So there is dysfunction of an organ or tissue after its formation. So what are the adverse effects which can occur? The mother is given a chronically a opioid drug. That will cause dependent on the fetus, manifest as neonatal withdrawal syndrome. This usually happens when mother is given pethidine during the labor. Keep on giving, and then the baby will be born with the neonatal withdrawal syndrome. So the pediatrician has to be ready with the antidote. Then female fetus exposed to diethylstilbestrol. There is increased adenocarcinoma risk of the vagina after puberty. Delayed. Next. Vitamin A analogs. When coming to that is about the adverse effect. This is the teratogenicity, causing abnormalities in the or deformities. Vitamin A analogs can produce the process of differentiation. Chronic consumption of ethanol can produce fetal alcohol syndrome. Next. So this has to be quantified based on the adequate data on animal studies and adequate data on human studies. Already we have given the FDA category of pregnancy drug and the PLLR. So based on this, the warning should be labeled the drug. This is the thalidomide crisis, as we all know. Next. What are the teratogenic effects of? Highlights into a teratogenic effect of some drugs. Antihypertensive. When you choose antihypertensives, AC inhibitors are absolutely contraindicated in pregnancy because they produce renal tubular dysgenesis, lung hypoplasia, anuria, oligohydramnias. Okay, thiazide they produce fetal electrolyte abnormalities and thrombocytopenia. Spironolactone causes feminization of the male fetus. Antidepressants, because now the pregnant women are going in for frequently for depression, we need to treat them. SSRIs can be given, but having a caution on paroxetine. Paroxetine will cause fetal heart defects. So fetal echo should be done. We can give other antidepressants, other SSRIs. Hormonal agents, corticosteroid, producing growth retardation and cleft lip. Diethylstilbestrol, producing vaginal adenosis late and the teenage. Antithyroid drug, neonatal hypothyroidism and goiter. Clomiphene can produce multiple gestation, neural tube defects. Synthetic progesterones can produce masculinization in a female fetus and hypospadiasis in a male. Phenytoin, anti-epileptic drug phenytoin. So fetal identoin, again we have to avoid phenytoin in pregnancy. It produces neurodevelopment abnormalities. Sodium valproate, producing neural tube defects, microsomia, developmental delay. Carbamazepine, producing minor craniofacial defects, finger rail hypoplasia. Next. So this is a fetal identoin syndrome produced by phenytoin. Next. Alcohol. The leading cause of birth defect is produced by alcohol. The fetal alcohol syndrome, birth defects, IUGR, microcephaly, retarded intelligence, and abnormal development. Amphetamines produces heart birth defects and IUGR, intrauterine growth. Bath salt is a designer drug made from various substances that resemble. These are all for drugs abuse. Ladies who are taking, pregnant women who are taking drugs of abuse. So this will cause narrowing of blood vessels, premature birth, IUGR, rupture placenta, and birth defects. Psychiatric drugs. Lithium can produce Epstein anomaly. LSD producing anomaly, stunted growth, fractured chromosomes. Alcohol, as we all know, fetal alcohol syndromes. Heroin can produce irritability, tremors. Cocaine can produce abruptio placenta and preterm labor. Antibiotics, common sulfamethoxazole, sulfa group of antibiotics can produce jaundice, hemolytic anemia, neural tube defects, oral clefts, and cardiac defects, urinary tract defects. Chloramphenicol, as we all know, gray baby syndrome, We no longer use chloramphenicol. Aminoglycosides can produce ototoxicity, neuromuscular weakness. More so when aminoglycosides are given with magnesium sulfate. Next. Yeah, this is the tetracyclines. Then warfarin. Warfarin will produce birth defect, abortion, hypoplasia, dicameron. Oral anticoagulants are contraindicated in pregnancy, and the anticoagulant of choice is heparin. Next. This is a picture of warfarin embryopathy. Next. Then cytotoxic drugs. Multiple anti-cancer cytotoxic, multiple fetal malformation, isoretinoin, CNS defects. Then high concentration of oxygen also can produce retrolental fibroplasia and blindness. Thalidomide, of course, our hero. Then misoprostol, producing Mobius syndrome. Vitamin D will produce Williams syndrome, that is infantile hypercalcemia. This is a picture showing retinoic embryopathy, and this is Mobius syndrome, incompletely closed eyelids, inability to move the eyes, crossed eyes, small, so cleft palate, etc. Next. Smoking, a very common problem. Definitely it will produce birth defects in the fetus. Caffeine, taking 1 cup a day can be safe. More than 7 cups not recommended. It can produce stillbirth, premature birth, eugia, miscarriage. So reduce the coffee taking should be reduced. Aspartame is an artificial sweetener. The diabetic pregnant women tend to take it more, so it should be avoided. You should be careful while you are taking it. It should be taken in very small amounts. Definitely avoid in patients with phenylketonuria. So this is about the adverse effects and teratogenic drugs. Now we'll see a little bit about the drugs recommended in pregnancy, the salient drugs, antihypertensive drugs. So it can be a chronic hypertension, it can be preeclampsia, it can be eclampsia. The first line drug are methyl-dopa, labetalol, hydralazine. Thanks to Madam who spoke previously. She has given the regimens and she has given the dosage schedules. Thank you very much, Madam. The first line drugs are methyl-dopa, labetalol, hydralazine. Second line drug is nifedipine, and the third line drug is clonidine. Refractory, when there is a refractory. Hydralazine, though it is first line, it is used only in emergency situations. Otherwise, we go in only for methyl-dopa. Prozosine can be used, but it is used only when there is a chronic renal disease complicating pregnancy. Sodium nitroprusside, when there is a severe life-threatening hypertension. So all these are given when there is a benefit outweighing the risk. So the preferred drug is methyl-dopa, labetalol, nifedipine. Next. Anticoagulant, as I insisted already, heparin is a choice. Then NSAIDs. Use of NSAIDs beyond 20 weeks could cause serious kidney problems in the fetus. There will be oligohydramnias. There will be premature closure of the ductus arteriosus. So the common NSAIDs which is accepted is paracetamol. Anticonvulsants, the safety of the other anticonvulsants is not true. We can go in for lamotrigine and levetiracetam. This is recommended nowadays, lamotrigine and levetiracetam. Others, benefit outweighs the risk. Antiprotozoal, we can use metronidazole. Anti-ulcer, ranitidine and omeprazole. SSRIs, as I told you, we have to be careful when we are giving oxygen. So citalopram and sertraline, the dose should be reduced, but the treatment should not be stopped. Hyperthyroidism, we can give propylthiouracil. Hypothyroidism, levothyroxine is the choice. Antibiotics, safest is amoxicillin, erythromycin, clindamycin, cefalexin. Antiviral, zidovudin and ritonavir are safer. And coming to our treatment with COVID-19, so we are not absolute proof, sir. There is absolutely not proof. So consider the risk and benefit, discuss with your team and decide upon the drug. Decide whether to give remdesivir or not, depending upon the risk-benefit ratio. Okay, acyclovir appears to be safer. Anti-malarial chloroquine is safe. When they have proved that artemisinin is also safe. So chloroquine can be given safely. But when you give primaquine, you have to think about the G6PD deficiency fetus. Next. Diabetes mellitus, human insulin is the mandatory. We can give drugs. Sulfonylurea drugs might produce hypoglycemia in the fetus. So the preferred choice is human insulin. And metformin they are freely giving, but metformin also causes some genital birth defects in the fetus. Antiemetics is vitamin B6 and doxylamine can be given. Drugs used during labor, local anesthetics and opioids will be liberally used, but this might cause respiratory difficulty in the newborn, so administer the smallest dose. The perinatal period, we have to give oxytocin, so this might lead to hyperbilirubinemia in girl babies, prolonged cortisol, adrenal crisis in infants. NSAID is premature closure of ductus arteriosus. Then dexamethasone, periventricular leukomalacia. Next. Coming to vaccines during pregnancy, live vaccines should not be given. Cholera, hepatitis A, hepatitis B, rabies, these are needed only if the mother is at the risk of developing the infection. So we have to give influenza and TT, tetanus toxoid vaccines is mandatory. The CDC recommends COVID-19 vaccination for pregnant and lactating mother because saving life is important. So the benefit outweighs the risk. So COVID-19 vaccination for the pregnant women is recommended. So this is about the mother, the pregnant women, the obstetric pharmacology. Next, coming to the drug safety, in little bit about the drug safety in lactation. So according to the American board, the need for the drug by the mother depends upon we have to think about the need for the drug by the mother, the potential effect of the drugs on milk production, amount of drug excreted into the human milk, extent of absorption by the breastfed infant, potential adverse effect that can produce, the drug can produce in the infant, age of the infant, proportion of feeding that are taken, the frequency of the breast milk, the amount of suckling done by the baby. So timing of dosage, toxicity, volume of breast milk, oral bioavailability of the drug, and the relative infant dose which reaches the baby, and the age of the infant also matters. Next. So what are the factors that are affecting the concentration? Maternal plasma concentration. A high maternal plasma concentration, drugs will easily diffuse. Maternal plasma protein binding. Highly bound drugs cannot reach. Size of the drug molecule. Again, the molecular size, big size cannot reach. Degree of ionization. Because the fetus is, the maternal blood is lightly acidic. So acidic drugs will be easily unionized and they will pass through. Whereas basic drugs will be ionized and stay in the breast milk, like morphine. Suppose if the baby suckles, the morphine will go and will cause deleterious effect on the baby. And the lipid-soluble, highly lipid-soluble drugs will easily pass it. Maternal, certain abnormalities in the CYP enzyme, pharmacogenomics in the mother can cause abnormalities in the metabolism, like codeine. So that can cause deleterious effect on the fetus. Next. So this is the dose. The infant dose received via milk can be calculated using the C formula, where C maternal is the maternal plasma concentration, area under the curve of the drug in the maternal milk plasma, and volume of the milk ingested by the infant. This is the formula to calculate the infant dose received via milk. Next. So what are the indications and contraindications? Very fast we will go. Analgesics. Meperidine. So we will have meperidine, that is, you have neurobehavioral depression, oxycodone, high infant exposure, aspirin can produce reeds. So safest is acetaminophen. Then anticoagulant drugs, phenandione can produce high concentration in the milk. Warfarin can be given. Then combined oral contraceptive All will suppress the lactation. So other mode of contraception has to be adopted. Cimetidine will accumulate in the milk. So ranitidine and famotidine can be given. Antidepressants and mood disorders. Fluoxetine will produce abdominal colic. Toxaphene will produce sedation. Lithium will produce lethargy and hypotonia. So we can choose sertraline, anti-epileptics, phenobarbital, high infant exposure, sedation might occur. So we can give phenytoin and valproic acid. Antihistamine, loratadine and lipropedin can be given. Next. Antimicrobial, preferable is penicillin, cephalosporin, aminoglycoside, and macrolides. Endocrines, for thyroid, propylthiouracil can be given, insulin can be given, levothyroxine can be given. Next. Immunosuppressive drugs, all are at risk. Drugs of W should not be given. Radioactive compounds should not be given. Anti-cancer compounds, you have to be very, very careful. So all these are contraindicated. You have to be very careful in lactation also. Next. So overall, there is a need for expanded research efforts for optimizing the therapeutic interventions in the pregnant women. Next. So consider giving a pregnant woman a drug to treat a disorder only when the potential benefit outweighs the known risk. This is mandatory only when the potential benefit outweighs the known risks. So thank the organizers and Professor Dr. Aruna for giving me this opportunity. Thank you. I should thank my postgraduates, Dr. Amirda and Dr. Deepa Lakshmi, for preparing these slides. Thank you one and all.
Thank you so much, Dr. Kudandemal. Such a great presentation. I should appreciate the efforts you have put in to prepare. It was very well shown in your slides. We are all indebted to hear from you such an extensive presentation. All of us from wholeheartedly from Department of Pharmacology, Kilpatrick Medical College, extend our warm thank you. Thank you so much. Now the session is open for any questions from the participants. You can again share in the chat so that Dr. Kudandemal can answer. Actually, I should pass one comment now given by our assistant professor, Dr. Anuradha, who actually prepared the quiz for the next session. Inadvertently, Dr. Kudandemal madam had covered all the points which I had taken as questions in the quiz. So I would like to tell the participants it will be very easy for you to answer the quiz. Any queries? Please raise the queries in the chat box. Shall we move on to the quiz session? Since I am not seeing any questions in the chat box. Once again, thank you, Dr. Kudandemal. I'll give the session to Dr.
Thank you so much for this opportunity.
Thank you. Thank you. Video.
So as we see, like this is the list of winners who have won the first quiz for the geriatric. First place goes to Vanita Shiba. She's from MMC and she has given 7 correct answers. The second place goes to Priyadashini Rajshekhar. She also has given 7 correct answers. But we have placed them 1 and 2 based on the number of seconds they took for answering the questions. For Dr. Vanita, it was around 206 seconds, and for Priyadashini, it was around 300 seconds. So that's the reason why she was placed second. And third place goes to Dana Prabhakar. In fact, like he's from Chengalpet Medical College, and he had the quick hands. It was only 63 seconds for him to answer all the questions, like nearly 6 questions correctly. But just being one question wrong, like he has been given the third prize. So congratulations to all of you. So first prize goes to MMC, second one Trinelveli Medical College, and third prize is for Chengalpet Medical College. So now we'll go on to the second set of questions. Last time it was around 100 participants who have given their responses. We'll see how much now. And as Madam said already, like most of the questions which we have taken has been covered in the session. So we'll see how many people who gets the first one. We'll just start the session.
Shall I launch the questions, ma'am?
Yes, you can launch.
Okay. First question. Each question will be given for 30 seconds and I will remind it last 10 seconds. Ten seconds more. Time up. Second question. Ten seconds more. Time up. Third question. Ten seconds more. Time up. Question. Ten seconds more. Time up. Question number 5. Last 10 seconds. Time up. Question number 6. Last 10 seconds. Time up. Question number 7. see the screen? Time up. Eighth question. Last 5 seconds. Time up. Ninth question. Ten seconds more. Time up. Tenth question. Last 10 seconds. Time up. Thank you. All the 10 questions were over.
We have come to the end of the morning session. Now we'll have the lunch break for half an hour. Let us come back together for the afternoon session at 1:30 p.m. Kindly log in at 1:30 p.m. Thank you.
Sundara, when a screen stop share button.
Welcome back to the afternoon scientific session. We, the Department of Pharmacology, Kilpatrick Medical College, takes pleasure in welcome you back for the afternoon session. This afternoon session consists of 2 talks by an eminent pediatrician as a clinician's view on the pediatric pharmacology and a pharmacologist about the pharmacologist's view on pediatric pharmacology. We would like to tell that the quiz for pediatric pharmacology will be immediately followed by the clinician's talk after Dr. Lata Ravichandran's talk, to save time for us to see into the results and all. So now let us move on to the scientific session. I would like Dr. Rajesh to introduce Dr. Lata Ravichandran.
Our next speaker of the day is Dr. Lata Ravichandran, Dean Education, Professor and Head of the Department of Pediatrics, Sri Ramachandra Institute of Higher Education and Research, Chennai. She graduated from Stanley Medical College and completed post-graduation in pediatrics from Stanley Medical College and Famer Fellowship. She has held a number of posts as member chairperson in many committees. She has been working as the backbone of medical education in NMC-related activities and as accreditation and assessorship for NAC. Madam has presented numerous papers in various national and international conferences and published a plethora of articles in many accredited journals. A very good organizer, she has conducted CMAs and conferences in various pediatrics and medical education related fields. Madam has received many awards, done research projects, and has guided many postgraduates in research work. We welcome you, Madam, to give us a brief idea of a clinician's perspective of pediatric pharmacology.
Thank you, Dr. Rajesh. And
over to you, Madam.
It's my pleasure to be a part of this webinar, and I really thank Professor Aruna and the Department of Pharmacology, Government Kilpatrick Medical College for this wonderful opportunity to be a part of you into what I would start off to say. There are 2 reasons why you are in pharmacology and we are in pediatrics. The word is precision. I think that is one commonality that we have, and that's going to be the exact reason why this talk is going, how this talk is going to be organized. Thank you once again for this wonderful opportunity. Can I share my screen now?
Yes, ma'am.
Is my screen visible?
Yes, ma'am.
Okay. So I started with a thank you, and my slide said it too. Pediatric pharmacology, a clinician perspective. Now I would like to change this a little bit. Pharmacology, pediatric pharmacology, I would call it as a combined perspective, because that's where the interprofessional education starts. It's not about what we are, but how collaboratively we are able to give a patient-centered approach. When we say patient-centered approach, it becomes even more precise when it comes to the population that the pediatricians are handling, which we call it as a vulnerable population, that is from birth to 18 years. So this is something which has been the interesting thing. The day when I was first entered the pediatric ward, I heard this all around. I was probably 3rd year or so when first time I was in pediatrics. Somebody said, children are not miniature adults. This immediately, gave me a thought, because all this while we were thinking they are big and they are small, and we didn't relate to what is it that is meant by the term telling children are not miniature adults. It is based on a literature, and we have to know why do we say so. So this is from the British Journal of Clinical Pharmacology, which said why children are not small adults. First, whenever the students come for any training, we ask them, why do you want pediatrics as a separate subject? Is it not that it is a miniature adult? Why did the undergraduate program initially had pediatrics as a part of what I could say general medicine? Said no, let it be separate. Means it requires unique training skills. And why? Because the anatomy and the physiology, there is so much of difference. Growth and development, which is an integral part to adulthood, happens during this phase. It's a very dynamic phase. Even within the pediatric age group, it varies. So the multiple anatomical and physiological disparity to pharmacokinetics, from the time the administration of the drug, absorption of the drug, and how it is transported, metabolized, and excreted, the maturity of the organs and the physiological functions are even changing within the pediatric age group. From neonatology, it's different during an infant and maybe in adolescence. So this constant change that is happening is what making us more vigilant when it comes to, saying that it is a unique thing. Children are not miniature adults. So if we are talking about pharmacology in pediatrics, it's a specialty by its own. Medication adherence is dependent on drug formulation, taste, appearance, and the ease of administration. So it's not that here the drugs, the patient themselves are taking. There is so much, slip between the cup and the lip. Its classical example is that of the pediatric medications. From what preparation, what kind of preparation, how the formulation is made, and whether it's tasty, the child is given or not given, what is the type of dosing it's given, what is the idea the administrator is having about the drug. Is the whole drug taken or partly which is it's coming out or it's being vomited? All of these considerations may sound that it's easily happening. It's not so. Each and everything has got an impact on the outcomes. However, one strong point that we have is it's young age. The development is taking place. So the metabolism many times also acts favorable. But if we are not careful, that's when probably the safety issues being threatened. The parent or the carers have their own beliefs. You prescribe a medicine, they may think it is too much. You may say 15 ml, they may think it's too much and they reduce half the dose. For what reason, we don't know. It is their mind perception, their own beliefs. So this, let's say immunization. Parent may say, I don't want to give injection to my son or daughter. There is a problem there. The perception is so much different. You really have to keep on educating them. Education is a key. I'm going to talk about the core competency that's important in pediatric pharmacology is communication. I'll be coming to that. So the perception, the risk versus the benefit. And also many times when the child shows a response immediately, it's not like adults, they immediately respond to treatment. There is always a threat of them giving up or lack of compliance to the medications. Many medicines are used outside the terms of their marketing authorization, especially the over-the-counter medications, and its use in the pediatric age group is something that we should be really concerned about. Most medicines used have only been formally tested for safety in adults. This is another challenge. It is they're not miniature adults. When we say in a clinical trials, today, maybe 10 years ago, it was different. Today, there are several clinical trials. Even if we take COVID vaccine, we say we'll have to conduct a clinical trial in the pediatric age group. Still then we don't give vaccine, but that was not the state probably a decade ago. There was a lot of a lack of trials of drugs for its usage in children. And conducting the clinical trial is also not easy. You just try to even get a sample of blood, it's not possible. Many times we resort to other easier method like salivary estimation of saliva or urine. Some other ways where we don't want to prick the child, because that becomes an important issue for that becomes a very, very important, concern for the parents, and that will lead to lack of compliance. Medication safety. This is to the most precise execution. So I'm coming back to that one term that we have that common is precision. And I'm going to even conclude by that term telling, if all of this that we are working towards is for that precision and towards the goal of optimal patient care and safety. That's the prime mantra. Probably all of us have to take it as a carry home message. So now we have to do a little bit of, seeing, I said all of this, but I'm just going to show you the WHO, who is the pediatric age group. The age between 0 to 18, from the time of birth to 18, is under us, is under what I would say under a specialized, scrutiny, because they are the ones, they go through these metamorphosis. So starting from preterm, it starts even in utero, the maternal part, the fetus is, and the growth is also, the mother and the child are together. I'm not going to that aspect because it's an antenatal mother and drug usage there, it's entirely different, pregnant mothers. But here it's about once the child has the outcome, starting from a preterm, that is less than 37 weeks of gestation, excuse me, 242 weeks, from a newborn who's from birth to 28 days. Even there we divide them into early neonate and late neonate, first 7 days and 7 to 28 days. The reason of this division is simply because the growth and development is constantly happening. And also there are certain diseases which are common during this, and the usage of certain drugs depends upon the type of diseases that are going to affect the age group. And remember, this is one age group where a lot of medications are being given for prevention and also as supplementation, which means I'm talking about the vaccines as well as the nutritional supplements. Then we have the infants less than a year, toddlers 1 to 3 years. Why are we worried about this age group? Is their behavior. How does it impact the medication and pharmacology is that many times children cannot be let on their own to handle the medication. There is a child safety that has to go along as a part of the medication safety, which we are going to talk more about in the challenges in pediatric pharmacology, which is purely related to the age group and the behavior of that age group. Coming to the preschool children, we have between 3 to 5 is the preschool, 5 to 8 is the school age. How does it impact? Preschool, you have to be more careful when they are at home, and the school age, you have to intimate what are the type of medication if there are any chronic illness that has to be administered, which is totally now independent of the parents and it's going to the responsibility of somebody else. So what about that communication that we do? I deliberately giving this perspective because most of the time as clinicians, we find these are the vital areas which actually causes the slip between the cup and the lip. So then we have the adolescent age group 8 to 10. It's the attitude. Again, it comes to their behavior and what is their attitude towards handling medications and the diseases. They sort of become semi-independent, but how is it that we can negotiate it that the compliance is there? Then the early, middle, and late adolescence, and of course, these are the 3 categories purely for the development part of it, and the impact of medications on the growth and development, especially long-term medications, is very significant. My talk around is not going to take too much into the chronic illnesses, but mostly around the ambulatory care, the medication and dosages, and what are the challenges faced in the ambulatory care and during an emergency. The objectives of my session is, what are the common clinical conditions encountered in pediatric ambulatory care? What are the common drugs and prescriptions in the ambulatory care? What are the challenges in pediatric medication, including a medication error? Because when we talk about today, that's one of the important international patient safety goal is medication safety. And when that is an international goal, in the pediatric age group, the vulnerability causes a double jeopardy. What we call it is compounds the effect. We have to be very, very careful. I usually say if you have to come into pediatrics or ophthalmology, you must have extraordinary precision, but I'm also adding the pharmacology and those who the pharmacy and the clinical pharmacists who are participating in the medication or all about the pharmaceutical approach to the pediatric dosing and medications. How do you prevent? The precautions and monitoring of the pediatric use, clinical experience. I'm mostly going to tackle this as what are the strategies that we have to meet those challenges. Whenever there is a challenges, it's not about how we face it, it's about how we turn them into opportunities for becoming better. And what is so special with the drugs in the pediatric emergency? We said Medication safety, it's a big field that itself requires precision. When it becomes pediatrics, it becomes even more precise. And we'll say pediatric emergencies, that's, I would call it as the ultimate unit of training yourself into what the precision is all about and how you have to act. What are the common clinical conditions in the pediatric ambulatory care? I would like to go from the perspective of a common man. Why would a child want to visit any clinic, ambulatory clinic? Why would you want to take your child to an ambulatory clinic? One, the most common, I would say 10 to 30% of the pediatric visits to the office practice is mainly for routine care or perceived symptoms, which means the mother feels there's a problem, but there's actually no problem. So it's your job to only find out that and reassure them, which means do not need a prescription by itself is an important decision, and we should be able to communicate it effectively and to the satisfaction of the patient. It's not about, patient gets satisfied, that's why I'm getting a prescription. I think that's one attitude that if at all this particular talk is going to eliminate from everybody is that there are situations when you have the right and also the scientific evidence to say no treatment is needed. You need to educate them and reassure. Why I'm taking this as the first goal is not to do something is more important in pediatrics than doing something. So it is important, that forms a major chunk, and you have to, stay tight on this. Because whenever you're introducing a child to a medication, even if it is a multivitamin, you are introducing them to vulnerability even more. So for routine care or perceived symptoms, feeding, growth, or a general care, behavior, there may be behavioral thumb sucking and all of those where we don't give any medications, a routine checkup, or some certifications regarding their, their growth and normal physical growth. That's the reason why which the child would want to visit a clinic. No drug prescription is needed. Again, I put it in red. You must have been more confident and more brave and absolutely thorough with your subject to say you don't need a medication. And I want that as to be communicated to anybody who's writing a pediatric prescription. It's okay if the patient says, I paid you, that's a usual story, but you have not even given any medication. So immediately we say we'll give multivitamin. Multivitamin is not something, it is a medication is a medication. It is only required whenever that you have to solve a problem. Where it is not required, we must be able to say no drug prescription is needed. Then what can you prescribe? You can prescribe non-drug prescriptions. That's also coming in the care plan. I will talk about it. Education, reassurance, and follow-up. We don't stop there. The three important mantra for pediatric practice is educating, that is reassuring them, and to follow up. Next comes the major chunk of what the pediatric practice is all about is for well baby and immunization. That's around 20 to even 40%, sometimes even goes up to 50% of your pediatric practice. Here the children are asymptomatic. There is no cause. They come with a trust that their child will be protected because you're administering some vaccine to them and preventing diseases. What they require is counseling. The question which is commonly asked is what is the difference between counseling and an education? Education is just transfer of knowledge, but counseling is an informed decision making. You're giving them, educating them with certain information that helps the patient to make a decision. So you will ask a question is, if immunization is a procedure, should they give a written consent? No need. The very fact that they come for a hospital visit for an immunization, that itself is an implied consent or a verbal consent is more than sufficient. But here you definitely have a drug prescription. Vaccinology today has become a separate subject because it involves so many things into that by its own. The decision to give a vaccine, the different vaccines combinations that are available, the choice of the vaccine, and safe vaccine practice is the term used for safe injection practice, documentation, communication or counseling, and knowing the medical legal implications. So these are the four cornerstones of what we call it as safe vaccine practice, of which drug prescription is an important thing. Because we are not only going to give, this is one area where all the routes of administration can be known. We have got different vaccines given by different routes. So again, education, reassurance, and follow-up. You don't leave it like that. The education, reassurance, and follow-up, that's something important. Even after administering a drug, it's important to call and find out whether the correct dose has been given correctly, or are there any challenges which the mother is facing, or is her understanding different from what you said. There is a lot. I'll just give you an example. They don't even have an understanding of what tablespoon and a teaspoon is. So we have to be very, very careful when we are giving the instructions. Then we have the group which is unwell and symptomatic, and they may require a drug. Again, I'm saying they may require a drug. Education, reassure, and follow up, and sometimes you may need to refer them. So this is the state which are the three categories which are commonly there in ambulatory care. The emergency is different. We will be talking about it. So the same thing, why would a child want to visit an ambulatory care? For routine, but you find that blue over there, which is the most important, is no drug prescription versus drug prescription. You have to be clear in those indications, and education, reassurance, and follow-up or a referral. So communication, I'm not even coming to the level of drug administration. Communication, verbal, non-verbal, and written, because we're going to learn about how we write a prescription, emerges as a core competency that we have to adopt today as the most vital thing that we need to when we are doing a pediatric practice or a pediatric medication or a pharmacology, whatever may be, the core competency is communication. So coming to the first category, what are the common clinical conditions in an ambulatory care? For routine care or perceived symptoms. Why did I put perceived symptoms? Many times the mother feels that the child is not eating. Father feels that the child is not growing. It's your duty to find out whether it's true or not. So that's where comes that no drug prescription is needed. All you need to give reassurance. But we learn to communicate. No drug prescription is needed. How would you convince? Parents should understand that drug is not a magic wand. Emphasis on the fact that they most of the time they'll ask, doctor, edavadhu oru syrup kudunga, en kulandhaikku konjam weight podattum. How do you handle this? It's your communication that's going to handle this. Do you think drug is the answer for that? No. What is the right thing? So parents should understand drug is not a magic wand. Emphasis on the fact, time, see, when you emphasize, when you are giving time consumption is more when you want to convince them for not taking a medication than when a medication is being prescribed. It's easy for you to just give something and send them away, but it will take double the time for you to convince them not to read. So tell them the importance by saying, I'm spending this much time is only to make you understand medications are medications. They are not food. The end point is the patient satisfaction and a care plan, which is mutually agreed without a drug. That's the most important. Again, I reiterating, while the rest of my slides are going to be more about how you're going medication, I would say this is the prime competence when you're dealing with the pediatric population. Coming to the next categories, that is one for the well baby and immunization and the unwell symptoms which are coming. Let us take first the next big thing which comes to you or which visits an ambulatory care is an well baby and an immunization. Now, here again, non-drug care plan forms the major component because it's not only for immunization that they're coming. We are going to talk about nutrition and feeding, which is as well as equally important. Growth and development, general care regarding patient safety, injury prevention, parenting, behavioral modifications, and counseling. That's the fourth thing for vaccine. Prior to any drug prescription, that counseling, as I said, safe vaccine practices takes a very major out of 100. 4 important things, as I said, safe injection practices, safe documentation, counseling, and knowing the medical legal implication. These are the 4 pillars of safe vaccine practice. So the counseling for vaccine, it's not that you tell them injection pota joravaro. That's not the way. It is about the risk of the disease and the what I would say the risk of the disease and the benefits of the vaccine if they take it. And what would happen if they don't take the vaccine? That's more important. Most of the time I find people counseling them saying, in the vaccine, that's a normal thing. Then you reinforce that there may be side effects for which you did not worry. So the 2 drug prescriptions that happens over here is for the vaccines and for the antipyretics. These are the common prescriptions that are going in your outpatient or an ambulatory care. So having known this, looks so small and easy when I say vaccines and antipyretics. But look at this. This is the range that we have. Now it's opening a new specialty, vaccinology. You have to choose the right vaccine, the right combination of vaccine, the various companies that are providing in different names. You have to choose the right dose, the route, and the administration based on what is, whether it's a normal child or a special situation. Chronic illnesses will warrant even change of those immunization schedules. So you see now how it's wide it's opening, where all problems can occur and where all mistakes can happen. So drug prescription is for vaccines. And if these vaccines are there, they have to be stored. Storage and handling vaccine by itself is a training. You see, it's opened up so many things. If you don't store it properly, if there is no verification of the expiry date, the different combinations that may be there and confusing. And if you don't have the habit of lifelong learning of verifying and going into the guideline book every day, when you take pediatrics, every day there is a new vaccine that's coming into the market. The position of these vaccines are decided by a vaccine committee. There are, the big people in the pediatrics, they are all formed a committee and they are there as committee for immunization recommendations. So they are producing guidelines. Every day you must have the habit. I tell the students, 30 years of practice, I don't do anything from my memory. Every day I learn to go into that website and see whether this vaccine is recommended or not recommended and what are the instructions that are going along with it. That is more important than saying from my memory I can tell. No, the attitude to be to go into that website and refer, and that's the lifelong learning process and an attitude that's getting inculcated when we are doing practice in the pediatrics, especially with regards to the vaccine. And you see this, there's an oral administration, there's oral polio, we take it so lightly, but there are so many things, information that we only know that are concerns or challenges the patient safety, and that we have to be cautious about. So then now the next group of people, what are the common clinical conditions? Now I'm talking about two ways. What are the common presentations and what are the common clinical conditions? Because they are not always the same. The presentation may be for different, but I'm only taken the most common reasons for which there will be an hospital visit, an ambulatory care visit or a pediatric clinic visit. It may be the most common we know is fever, running nose, sore throat, earache, cough, breathing difficulty, not feeding, crying, headache, abdominal pain, passing worms, constipation, tired, body ache, lethargy, vomiting, loose stools, urinary symptoms, skin lesions, poor growth, seizures have not added, poor scholastic performance. So these are the common reasons with which the patient will bring. The patient will not say, I have anemia. If you think fever, running nose, and sore throat, it may be only an acute upper respiratory infection. I've put common conditions which are there. If there is fever, running nose, and a breathing difficulty, maybe an asthma. Fever, running nose, a breathing difficulty, cough, maybe even a pneumonia. So that's all are categorized into ARI, acute respiratory illnesses, which forms a major chunk of the hospital visits in this category, that is the symptomatic children. Then we have fever, febrile illness. Fever is very common because this is only going to determine which are the common drugs that are getting prescribed. Loose stools, diarrheal diseases, very common. So fever, vomiting, and diarrhea becomes a diarrheal disease. Fever, vomiting, headache, and seizures becomes meningitis. You see how many pathways that we can create, but these are the common reasons with which they come. Or fever, not feeding, crying, sore throat, and a earache may be an otitis. So the presentation is that of the various symptom categories, which will now say the common symptomatology which they are towards the diagnosis of a range of disorders. ARI, diarrheal diseases, febrile illness, febrile and non-febrile seizures, urinary infections, nutritional deficiency, I wouldn't say anemia, which anemia is top, helminthic infections. I've just taken only the top cream from this, and there may be visits for cut injuries, some safety issues, they may come for that. Because that time we may have to recommend look at the immunization schedule and recommend a vaccine. So these are the common reasons with which, why would a child want to visit you in your office? So what are the groups of drugs? So you see now so many combinations. These are the floating groups of drugs or the categories of drugs that are coming out. You can have antipyretics, anti-inflammatory, antibiotics, cough syrups, bronchodilators, antihelminthic, corticosteroids, multivitamins, antiemetics, oral rehydration, antihistaminics, antispasmodics, and hematinics. The reason I put is these are all only compressed categories. Now I'm going to open one by one. Then you'll know how much is the difficulty level is going that I talk about a precision in this. You need to be extremely alert when it comes to pediatric medication. I've taken only one of this, the antipyretic alone. Now you see now. This is paracetamol. I've just taken paracetamol. So the drug is a prescribed drug. Antipyretic analgesic, sometimes you do get over the counter, but then for us, it is a prescription, paracetamol. You see, P500, suspension, P250 syrup. Then you have P125 milligram suspension, 120 per 5 ml paracetamol suspension. Paracetamol drops, this is the most villain. You know, you put suspension, they will give 5 ml of drops. Then it becomes toxicity. It's 1 ml is 100 milligrams. So you see how carefully it's not about your prescription alone, what they understand out of the prescription. Then you have 500, 650 paracetamol tablets, where they can't, you know, spend to buy. You give a tablet, ask them to, you know, you break it into 1/3, 1/4. You know, that's the way we are sometimes doing. So most commonly used drug in the pediatric ambulatory care. Now you see the permutation combination, how much exponential it has become. We can't even handle it. So I'm going to take only paracetamol as an example. What are the challenges in the pediatric medication? So having seen all this, I've just given the background and the need for this particular talk and why we should work together. Again, I would love to collaborate with more the number of people, the more the merrier, and more you take help towards a patient-centered care. So what are the challenges in pediatric medication? One, it's not that you just prescribe a dose and accurate weight recording. It's not about accurate weight calculation. From recording it starts. They have to calculate the weight correctly. So you must have a calibrated instrument, proper instrument, and make sure that the right weight comes. If it's not calibrated 1 kg more, then you're making a wrong decision on your calculation. And correctly transcribe. It's not about only calculating the weight and transcribing medication. I'm sorry, writing a prescription and transcribing medication. It will say 16 kg, but somebody else will enter it as 26 kg. You know, that's the transcribing I'm talking about. So you have to be very vigilant. Second, healthcare provider must make weight-based calculation for every prescription. It's not Torayama. For every prescription, you must make an weight-based calculation. And preferably the calculation, you know, it is all done in kilogram. So sometimes there are two systems. Somebody will put it in pounds. So you have one more work. You have to convert that pounds into kilograms. So there also errors can happen. So the correct preparation and concentration of the medicine must be included in the dosage calculation. I gave a paracetamol as an example. So when you're calculating, are you calculating for the total dose and what are you going to prescribe? A suspension which is 5 ml 500 milligram or 5 ml 250 milligram or anything else. Have that in mind when you're doing the calculation. And most important, nobody should be without a drug dosage book. The first instruction we give for any even undergraduates when they're entering pediatrics to have a drug dosage book. But it doesn't stop there. Which drug dosage book is the standard one? Because one in between the other, there is a difference in the dosage. So you must prescribe the standards, reference standards for every drug prescription. Standard pediatric dosing references. Difference exists between dosage books. Harriet Lane is the one which we are usually recommending when it comes to the postgraduate training because that is considered as a reference standard. The daily total dose may be divided into multiple doses to obtain appropriate frequency. So when I had this, I'm just an encounter which we had with a patient and one of the CRI who came for the first time. There was an adolescent girl who was around 45 to 50 kg. So I said, prescribe one SOS tablet 500. The next patient, 1 minute, I forgot. I was just talking to about the vaccine. I was advising on the vaccine. I said, please prescribe paracetamol. And immediately when it comes, luckily I have the habit of checking. It says 500 milligram, 1 SOS. So you see, it's not her mistake. It's not my mistake too, but that when we not communicated and we think that they know dosage calculations, so the errors are bound to occur. The slip between the cup and the lip is too much. So what are other challenges? Communication with the parent and caregiver often will occur without the medication. So most of the time you're describing something which she doesn't know. She will shake her head. We'll say suspension, give like this. But the moment she buys the medication, she gets confused. So that is another area where, you know, the pharmacist will play a vital role and also the nurses. So we need to have a system in place. The prescription must be legible and correctly interpreted by the pharmacist. Here again, the most common problem is with the decimal point. Normally, you have to put a 0 before any decimal point, but doesn't happen. It says point something. So the decimal is missed or something is missed. So there is a problem. The pharmacist must dispense the appropriate medication, its appropriate formulation, labeled with the appropriate dose and frequency. That's the final outcome. So what we have prescribed, they have understood, they have transcribed, they have correctly understood, they are correctly dispensed and labeled and also explained to the parents. You see, this is becoming really a major challenge. So coming to the pediatric age group medication, I'm putting vulnerable and potential risk for errors. Is it a double jeopardy? I would change that into a double opportunity. An opportunity for you to learn more about this measurable element, which is supposed to be the top of the international patient safety goals, that is medication safety, and more so in the category of pediatric. If you're trained in pediatric dosing, then you become an expert in the medication safety. So that's the level we are dealing with. That's the area, precise area of training, which will give you an exponential competence. So medication errors are the most common medical errors, and the pediatric population is particularly vulnerable to medication errors simply because of all the reasons that we have discussed so far. And errors can occur at any point in the medication process, either ordering or transcribing, dispensing, and medication administration. I've taken the three pillar areas where we need to actually look into. So this is some medication errors, what we need to. This is some of the statistics that I have presented over here. Sorry. You can actually see, 1 minute. You can actually see outpatient medication errors in children younger than 6. One, the most common is incorrect dose. Second, iatrogenic errors can happen. Tenfold dosing errors. This is very common with paracetamol, where you prescribe 5 ml drops instead of a suspension. Other therapeutic errors, that's even up to even the choice of the drug. Someone else's medication, the prescription changes and they are taking someone else's medication. Look at this. This is something which is preventable, and wrong medications. So you see all of this, this is the percentage of the medication error, and commonly 5 to 27% of medication orders result in an error. And a recent scoping review found that the most prevalent pediatric safety issue were medication related issues. And that's the reference that I have put. And this is also the reference that I have taken it from. Just 1 minute. I have some problem with the, okay. So what are the common pediatric prescription errors? So I'm going to take 3 prescriptions and, sort of discuss this. And maybe you can put in the chat, what do you think is the major problem with this, in this prescription? Even somebody can actually make a comment. Anybody wants to try? Yes? Any participant? Okay. So the allergy is not documented. That's the most important. The allergy, even I've seen allergy to paracetamol. They have a tough time with such children. Weight is not there. And 5 ml of what? Suspension. So this is the wrong prescription. So this will lead to a lot of confusions. So how do you write this? So this is how it is. So you see, just one paracetamol, we need to concentrate so much. Weight 10 kg, suspension or syrup 5 ml, 125 milligram, 5 ml every 6 hourly, and there is no allergy. Let's take one more. What is the problem with this? Identify the medication error. It says 5 milligram per oral. It's giving the total dose 5 milligram and it says 30 ml bottle, but there is no mention about how much ml should be given. So this is what it is. Ondansetron 2 milligram per 5 ml, 5 ml per oral twice a day. That is, you put 101 per day, 30 ml bottle number 1. If already these are in a predetermined electronic media or in a form, then probably this error would not have happened. When you just write a prescription, it's an open prescription, you're fatigued. After 5 patients, your tiredness comes. There is every chance that errors can happen. Third, look at this. What is this? Anybody can find out? This is very, very common. I've seen, and sometimes, it gets executed also. Rotaviral vaccine is not an injection. Route of administration is the drops, oral drops. It's a major thing. They also provide them with one nozzle. So they immediately, it's like a syringe. So there are times when they put a needle and even inject it. So this is something which we are real concerned. So the strategies to reduce the incidence of pediatric medication errors, the WHO has taken it as a big theme and says medication without harm. This is for the whole population, not necessarily the pediatric population. And it is a theme for the third global patient safety challenge. So we come under that, and pediatric age group becomes the most precise group, or what is it, the exclusive group where this can be executed to the precision. So coming to the strategies, I divide, though these strategies are from the West, I have taken the major categories as that medication ordering and transcription is one category, we must have strategies. Medication dispensing is the next, that's purely the role of the pharmacist and the the pharmacy to handle it, and medication administration, which also involves the patient and the families. So this is one. Let us take prescription order writing. As I said, most of the time, the prescription writing is in our control. We are training undergraduates. So the most important place where we can make a lot of difference is in our training. The training and education is one key to everything, whether it may be into the curriculum or subsequently when they're coming as focus group, when they are doing the medication safety training, whatever levels, even as an in-service training before they are CRRIs entered into the wards. I think this is most important. So the prescription order entry can be either manual and made like this. This is giving you a minimum example of how you can actually make things easier for the prescription. So, to reduce the errors. So if you put the categories, they are forced to write it. If it is not complete, the pharmacy will not entertain such prescription. I think that one single mechanism can at least bring down the errors by almost 50% if you can adopt a standard format or a form where prescription, it also forces the students to learn how to write a prescription. I'm here honestly admitting, when I finished my MBBS and started practice, it was like writing a prescription seemed to be the biggest challenge, because we are not formally trained. But now it's not. So CBMA curriculum is also making it mandatory that they learn how to write a prescription, I think from the 3rd year, from the time they enter into pharmacology. So then we have clinical decision support. The other thing is the decision support influences the drugs that we are taking. If you have a common guidelines, we go by the guidelines. One of the reasons to get so much in private practice, for the same fever, there is multiple decisions that are happening and multiple prescriptions that are coming. So that is one thing. You must have a clinical decision support group, which will say, like what we did for COVID, this is the prescription that we should give. Pharmacists support unit-wise. After giving the prescriptions, we do have B-Pharm and M-Pharm, as well as PharmD students who are posted with us. We're very happy to have them, because each of them will actually look into the prescription, look for any errors, then they will even explain it to the patients. I know some of the clinical, what we call it, pharmacy practice, as well as PharmD, some amount of, they also do a prescription writing, just like nurses practitioners. So they are pharmacy practitioners. Prescription audits. This is another one simple mechanism by which you can really make a lot of change. You just go one day into the ambulatory care, take around 100 prescriptions, ask the students to audit so they learn. Out of that, data has to be presented. Many times when you say you're wrong, nobody is going to accept. But when you present data, we doctors, generally the doctors group, need data to actually change ourselves instead of saying you made a mistake. These are non-punitive ways by which we can make some corrections. And medication safety, it's a process. And where it's not only about identifying the errors, but also to find out root cause of what caused those errors, and also do a training so that it doesn't happen again. Of course, training and education becomes a major component. The next thing is about medication. Dispensing is all about how the prescription is being entertained in the pharmacy, but here the different formulations, the different mechanisms by which it's stored and how it is being dispensed, and sometimes labeling has to happen because you do the formulations in the pharmacy, and the medication safety committee. Again, pharmacy audits, I wouldn't say audits, it's an accreditation. A pharmacy getting accredited is an important step in this because it sets right many of the SOPs that have to be followed in dispensing, and of course training and education as always. Now, one question is about training and education is, I've just added the third is it's not about only the training that you do focused to your own staff and the staff and pharmacy staff, but it's also about introducing a small part of it into the curriculum and integrating it from undergraduate, postgraduate, as well as whatever level they are going, so that the clinical aspects of it, you can even use standardized patient, or you can even use them for doing audits so that they learn the process. Coming to the incidence of medication errors, medication administration. This is a big area where most of the people, including the doctors, the pharmacists, as well as the patients, have to play a vital role. You have the medication safety policies and procedures at the institutional level. Role of the medication safety nurse. I think one important thing that you do in the hospital is to appoint a medication safety nurse. Can be one or many, who just goes around looking into these facts: right patient, right drug, right time, right route, and right dose. The nurses are the ones who are involved in giving the medication when they administer medication. The two, I would say from our experience, the two things that improved our medication safety was to provide a medication safety box into every of the inpatient wards, so they keep it locked, number one. Second, the drugs will be given only by the staff nurse. And they will go through all this. Right medication, there's a verification. You verify the ID of the barcoding is done. That's another way by which you can identify patients. Barcoding, the medications are having the barcode, so it says this person only receives this medication, and the order is signed by the doctor, is verified, and then the right patient, the right dose, and the right route of administration is done. And this is getting audited. So you need to give those skills. It's actually, I'm starting with the training and education. Medication safety is a key quality indicator. So if you need to take it as a key quality indicator, it has to go into your blood. So that should become an important part of your curriculum, whatever curriculum that is concerned with the patient-centered or the interprofessionals that we are, what we call as healthcare professionals or the providers who work as a team in patient care. So the role of medication safety nurse is very, very important. Medication boxes, medication safety audits, reporting incidents. If there is an incident, one of the most important things, unless you know what's happening, it's all under the carpet. You think everything is fine. So there must be a way by which there is a non-punitive action, but this reporting becomes important to make a systemic correction. Adverse drug events reporting. These are all the forms that you should have in place. If there is, and you should educate every doctor, every healthcare provider, that if there is an incident, it has to be reported only because it has to care. It should not happen again. It may be an adverse, it may be a sentinel event. Sentinel event is something which is very, very dangerous, that takes away the life of the patient. And of course, patient and family education, patient and family education, patient and family education. Here, a dispensing paracetamol, the mother should be told which is the spoon, which is the measure that you're using and how you have to give. And if the child vomits, what you're supposed to do. And it doesn't stop there. There in all abroad, there is a nurse who's calling every day, wherever there is child received a prescription. She calls every day to find out if there are any issues with the medications. The problem is more, especially with anti-epileptic drugs and antipsychotic drugs, all of this, but there must be a follow-up call which is going and guiding them. Not all parents are smart. Some of them have got beliefs, some of them don't want to even listen to, some of them are over enthusiastic in doing things. You must know to gauge that, and you have to continuously keep them under your fold. So that was the about ambulatory care. Is there any questions at this point? I would like to take it before I proceed with a few more slides on the emergencies. Are there any questions? Okay, if there are no questions, I will progress now. I said pediatrics and pharmacology are very close. They're two P's. Very close. Medication safety is the prime goal throughout the world. And when you take pediatrics, the precision comes. And within pediatrics, different age groups. Now we are going to go to the ultimate, place where the challenge is at the highest. That is, in what are the common pediatric emergencies. We are talking about oral drugs, but this is a condition where you have no control of, you have very, very short time, and you have to be very careful with all the medications given. It's not about being careful, it's about preparation. You don't wait for an emergency, but you train for an emergency and set everything so perfect and check every day and put into the log and make sure when such a situation comes, you are not handicapped. So the common presentation in the pediatric ER will be an unresponsive. It's not only about medication, but also the equipment. I would add to this medication and equipment because it's almost same. There you calculate the drugs, here you calculate which size you have to take. This is very, very important. So this is a place which the adrenaline rush, I think, will be at the highest. So the common presentation in the ER is an unresponsive child, a convulsing child with respiratory distress, cardiac or respiratory cause, and child who's bleeding or traumatized. So the emergencies are a trauma, poisoning, accidental and non-accidental, cardiorespiratory failure and arrest, shock, with a septic, hypovolemic, anaphylactic or cardiogenic, and status epilepticus. These are the common presentation, the emergency. Do you think you have a time anywhere there? How long is between the adults, the resuscitation time itself is shorter in pediatric age group. So, and the drug dosing that we are going to do is extremely, what I would call it as calibrated. So you have to be very, very careful. The most important thing that helps you with the decision of the dose is this: categorizing your patients into the various triaging categories in the ER. You may ask, there is no drug over here, madam, why are we worried? No, this tells you, look at that category 1, immediate, emergency within 10 minutes, urgent within 30 minutes, urgent within 60 minutes, and non-urgent. This triaging is very, very important. It gives you the time, or says you don't have time. In the emergency itself, we don't have time, but then you need to have 10 patients coming in, you need to prioritize. So this triaging, or what we call it as a decision-making, clinical decision-making support is important. It's there, put up everywhere. You have your own guidelines, you evolve it, but follow it. Then, these are the challenges with respect to pediatric medication in emergencies. One, the emergency kits, if they are not organized or not checked or not kept ready, there is an undue delay, the outcome is bad. Straight, you're not prepared, you will have a bad outcome. Even if you're underprepared, you will have a bad outcome. It's all or none. Well preparedness, keeping all necessary equipment. I'm talking about equipment equally as much as the drugs. Having drugs stored with the policies on how to dilute. Suddenly you will forget how I should dilute, how I should make this drug. So there must be support from others who are away from the process of resuscitation to guide you on these medications. Preference would be to have a pharmacist in the emergency department who will give you immediate support on all the drug dosing and other information. You can have an online drug information system or an information system in the emergency department, which gives you, and in most of the places, it is there. Having drug dosing charts, and that is independent of the weight. Now, all this while we said we will calculate the weight, transcribe the weight, but now is a situation you don't have time to even weigh. You must have some criteria by which you make the calculation independent of the weight. So this is the recommendations that we have. This is a list of drugs. First, you create a formulary of all the drugs that are needed. Make sure you categorize them which are at high risk, which are what we LASA, look alike and sound alike. You know, they will look alike and sound alike, so you should not, in your hurry, mistake, use one from the other. Then you must know how the dosaging is done, what is the pediatric dosaging, and for which age, how much you calculate, what is the drug dose and how they have to be administered. Create a standard formulary for pediatric high risk and commonly used medication. Keep the high alert medications away in a medication box. Don't keep them in the common place. Standardized concentration of the high risk medication. So there must be information and you also have to standardize it. One important thing that you may require in the emergency is the crash cart. The crash cart should contain all pediatric formulations, and in the pediatric formulation, and every day there must be a nurse who check it and also countersign the logbook that it is checked. Okay. Reduce the number of available concentration to the smallest possible number. Don't take too many concentration, just the smallest possible number. When you have too many concentrations, then you're likely that you may use one for the other. Provide recommended pre-calculated doses. So if there are pre-calculated doses, if there is some instruction, please use that. Measure and record weight in kilogram only. While I'm saying this, you must also be able to do things independent of this. This is called the Boslow's tape, where the child is come unconscious. You cannot weigh the child. If you don't have a reason weight, you just use that, and that tape will give you for the length what is the dosage of the medication and also the size of the tube and what you want to use. And this is the crash cart which is there, and this has to be perfectly checked every day. And the training on a pediatric emergency should continue. It's not about the availability of the drug. It's not about receiving a patient in the emergency, but you should also have the competence to address and know what you're supposed to perform. It's a team performance. The PALS training, the NALS training gives you all that. It is not only for the doctors, it is an interprofessional training. The team should know how to handle this. And one who assumes the team leader should be able to give the instructions appropriately. So this is how it works. Here's an example for the ET tube. You see how he's doing. A child is lying, he's just measuring it and he's getting the information. So a few more recommendations. This is from our chart. These are the trays which are set for us. Link-based tool, we already said. Implement and support the availability of pharmacists, we already discussed. Standardized set of orders, embedded best practice prescribing and dosage maximums. Set trays. You can actually see, you can see medication tray 1, tray 2, tray 3. These for the different circulation, breathing. You see how the trays are set, and this is it's also in the book, SOP book. So you can actually refer to and you pick the correct tray. Then again, implement process screening. That is process. Then the other thing is promote development of distraction-free medication safety zone, especially when you're mixing medication like potassium. You must have a separate zone where there's high alert medications are being prepared, and it should be free of any distraction. And of course, this must have a two provider independent, should always check for high alert medications. This is the other thing, computerized order entry. If you're ordering for a particular drug, there must be a computerized order entry. And I said clinical decision making, or called clinical pathways, are very important in pediatrics. And of course, you calculate if you're calculating only in kilograms. And always only dosing rules, including upper limits with the information system which provides the drug dosage which comes in the ED itself. You can just click, by the click of the button, you will know, and also to check on adverse reactions when you're using multiple drugs or when the patient is already on drug. There must be a mechanism by which you capture the drugs already taken by the patient. That's what encourage community. That is, if you are a private practitioner, always provide them with the list which they will always have in hand on the medication that you're taking. There may be an accident where you may not be able to communicate. So it's important that if they're already taking any medication, there must be a proper information. Normally, if there is a connect between the private practitioners and the tertiary hospital and a centralized mechanism for what we call documentation, giving an ID itself will populate all of this. But we don't have that system. Only in certain places we have that connect. Create and integrate a dedicated pediatric medication safety curriculum. See, this is something which we all can do. I think if at all there is one outcome of this, even this teaching and learning, there must be a competence defining for medication safety in every curriculum, whether it's UG, MD pharmacology, in pharmacy practice, whatever may be. I think there must be a common module and up to the level of what you can execute your licensing. And here you have nurses, physicians, respiratory therapists, nurses practitioners, physician assistants, pharmacists, pre-hospital providers. These are the team. I would rather want the Department of Pharmacology to lead this training. Take it up as a goal of medication safety, responsibility of medication safety, because the key lies in training and bringing people together. And I think the Department of Pharmacology should play a lead in this. Of course, for competency assessment doesn't stop with it's like intubation. Once you do it 1,000 times, you do it 1,001 again, you'll fail. So you have to develop tools for sustenance of the competency and competency assessment. and dispense standardized delivery devices for home administration. So when you want to give administration of medications, you give them the standard mechanism. Normally, we prefer to give using a syringe. Any oral preparation, suspension, we give them a 5 ml or 10 ml syringe. It's easy. You just measure it and take it, and just in the side of the cheek, I mean, inside the mouth, you just push it in, the child will swallow. Otherwise, the mother will have such a big problem with giving with a spoon, spilling it all over. They will waste 2 bottles, and then finally she'll end up getting frustrated. Okay, so employ advanced counseling. That's another thing as a teach back. When medication for home use, you don't stop with just prescribing and even teaching here. You have to call up and find out. Normally, the nurses practitioners do that. There will be, especially with the pediatric age group, you need to constantly check for compliance and also the correct technique. It's just like we use an inhaler. We take so much pains to teach inhaler. That much of pain should also be in giving the oral medication or whatever form that you are advising, even intranasal. You have to keep on reinforcing on the competence of the parents, because we are depending on them. They are not trained people. We are only educating them. So that training should happen. So that's about the emergencies, and we have come to the last part of it. If at all you forget all of this and you thought you wasted time, this 40 minutes with that, the one thing again, I'm going back, precision. This is an area which requires extraordinary precision, commitment, and to an understanding. If even one mistake happens, there's a life is at stake. So if we are thinking about what we call optimal patient care with safety as our priority, I think this pediatric pharmacology is the area where you can train. I'm not saying that will make you an expert. It's not only expert in pediatrics, but it extrapolates to other areas too. You develop it as a habit. It's not about the knowledge, it's not about the skills, but the attitude that constantly reminds you, let's be vigilant. And that's the level that will make you to go into this deep to the level of precision with which you want to execute it. So summary, pediatric pharmacology is unique and requires specialized competence. So we need to bring it into the curriculum. Challenges in pediatric pharmacology are opportunities for learning and training. I would convert them into opportunities. This is where somebody can emerge as a new expert and a specialist. And that's probably everybody will look up to us for such a safe situation, because anywhere we are satisfied only when we feel secure and safe. Medication safety is one of the prime international patient safety goals, becomes compounded in the pediatric age group. And that's every clinician should get that into the mind. It's not a perspective from a clinician, but I think it is more or less like a discipline among the clinicians. Training in pediatric pharmacology is not only developing knowledge and skills, but an attitude that embraces quality and patient safety to its precision. I think these are all interrelated. And ultimately, if that message is gone deep into us, I think that would be the outcome of this whole talk. Thank you very much for providing me this opportunity, and I'm open to questions now.
Thank you, Dr. Lata, for such a wonderful presentation. It is not only about the pediatrician's point of view on the usage of drugs. We could see an educator's point of view, how to educate and train our UGs and PGs towards the medication safety and how it could be emphasized. And the role of pharmacologists, as you rightly pointed out, it is gaining importance in more hospitals. Even in ours, we are entering into the hospital side. Slowly from the place of antibiotic usage and safety to pediatric, that is the prescription auditing. Slowly it is picking up. I know in some of the hospitals, in some other states are having a unit inside the hospital itself to look into the prescription auditing and the safety. I hope in another future few years, it will be a great importance for the pharmacologists to be associated in the main care of patient care in giving and dispensing drugs. Thank you so much for this presentation. Any questions from the participants? Kindly share in the chat box. Dr. Lata will be very happy to answer the queries. I think we are not getting any questions at present. I would like the participants to even share your questions a little later also, so that we can just pass on the questions to the speakers and get the answers and share it with you all. Now, before the talk by Dr. Vijayarani about the pharmacologist's view on pediatric pharmacology, I would like to call upon Dr. Kirtana to have the quiz on the pediatric pharmacology. This is because we would like to have little time for the analysis of the quiz winners. I request Dr. Vijayarani to bear with us 10 minutes to finish the quiz and start your session. Thank you.
Hi everyone. We just wanted to announce the result of the previous quiz. So for the obstetrics and gynecology, we found that Dr. Ashwini from Stanley Medical College, she got 9 correct answers and she gets the first prize. And Dr. Saraswati Balu, she is also from Stanley Medical College. She answered 8 questions correctly. And next comes Dr. Niveda Raju. She is from MMC. So these 3 people will be awarded the cash prize for the obstetrics and gynecology session. We'll go on to the next one.
Shall I start the questions, ma'am?
Yeah, you can start.
Okay.
The same
First
thing,
question.
10 questions will be given.
Each is 30 seconds. First question. Ten seconds more. Time up. Second question. Ten seconds more. Time up. Third question. Ten seconds more. Time up. Good question. Ten seconds more. Time up. Fifth question. Last 10 seconds. Time up. Sixth question. 10 seconds more. Time up. Seventh question. Last 10 seconds. Time up. Eighth question. Last 10 seconds. Time up. Ninth question. Last 10 seconds. Time up. Last question. Last 10 seconds. Time up. All the questions were over. Thank you.
Hope everyone answered it very well. We'll get back with the results in a few minutes. So going on to the next session. Our next session is by Dr. Vijayarani Ma'am, Professor and HOD, Department of Pharmacology, Chengalpet Medical College. Madam graduated from Government Thanjavur Medical College and completed postgraduate degree in Child Health and Pharmacology from Madras Medical College. She has a teaching experience of over 9 years. Madam was instrumental in establishing Chengalpet Medical College as an adverse event monitoring center and has served as a subject expert in the clinical trial inspection by CDCSO. Madam has organized many workshops on good clinical practices, pharmacovigilance, and pharmacogenomics. We welcome you, ma'am, to enlighten us with the pharmacologist perspective in pediatric pharmacology. Over to you, ma'am.
Good morning, everyone. First of all, I thank Professor Arna madam for this. Hello, is it audible?
Yes, ma'am, you're audible. You can continue.
First of all, I thank Dr. Arna madam for making me part of this learning session. I'll share my screen now. Almost we have reached the end of the session, and so I shall proceed. And as far as pediatric pharmacology is concerned, already the earlier speaker, the previous speaker has told, don't treat me as little adults. That is the main core of providing medicines for children, especially with regard to dosage calculations. So the session outline will be developmental pharmacokinetics and dynamics, extrapolation of efficacy and safety data to arrive at dosage information, the challenges in drug delivery, formulations and compliance issues, pharmacodynamics, pharmacogenomics, adverse drug reactions and pharmacovigilance, TDM in children, rational use of medicines in pediatric patients, and kids list, challenges, regulations and incentives in pediatric drug development, and pediatric
One
pharmacology.
second, sorry to interfere, Dr. Vijayarani.
Yes, madam.
You have not shared your slides. It's
Not sharing.
shown.
Yes, madam.
Yeah,
I
yeah.
shared
You have to share your slides.
Yes, madam. I started sharing. Okay, one second. Share screen.
We could see only your
one second,
video.
madam. Select a window or application. It is coming.
Select the window, ma'am.
Select
the
a
screen.
window. One second. Share.
In your laptop, it should be there as a opened PPT.
Open file is there. Open file is there.
Yes.
Is it all? Is it?
Yeah.
Is it,
now I think you are getting. Yes. Yes. We got. Correct. Now it is evident. You can.
Screen?
From the first slide, I think it's better to start. Thank you.
Is it visible now, madam? Madam, is it visible?
Yeah, it is visible. You are audible. You can proceed.
Okay. Shall I put for a slideshow?
Yes, ma'am. Slideshow will be better, ma'am.
Yeah, that's what. Is it okay now? Is
yes,
it okay now?
It is perfect now. It is
fine.
perfect, ma'am.
Okay. Thank you for the short delay. Now we'll go to the session outline, and here we'll look into about developmental pharmacokinetics, extrapolation of safety and efficacy data from adult informations, and drug delivery and formulations and compliance issues, pharmacodynamics in pediatric population, pharmacogenomics, adverse drug reactions and pharmacovigilance aspects, and therapeutic drug monitoring in children, rational use of medicines in pediatric patients, and the kids list. Then challenges, regulations, incentives in pediatric drug development, a brief intro, then pediatric pharmacology as a subspecialty. Moving to the next slide, as my previous speaker told, pediatrics age group, they are a heterogeneous group of patients with various biological events progressing from somatic growth, neurodevelopmental maturation, and finally reproduction. So the knowledge of pharmacokinetics and pharmacodynamic characteristics are very limited in children. Whatever data that medications are given is based on adult information only. So it imposes challenges in the drug usage, dosage, and prediction of adverse events. So there are ethical issues including children in drug research. And there are medication errors, which in turn limits the pediatric specific formulations. Medication errors is additional burden. Also, there is limitation in the pediatric specific formulations. So proceeding to the next pharmacokinetic details. Pharmacokinetics is, as we all know, absorption, distribution, metabolism, and elimination. So pharmacokinetics through the enteral route. Gastric pH, what are the changes in the pH as the child grows from the newborn to up to young children. It is alkaline in the first 24 to 48 hours of birth. It is neutral after 72 hours, or it takes up to 10 days, and it reaches adult values. The pH of adult value is reached by pH of 3 is reached by 2 years of age. So what happens when the pH is neutral? So the acid labile drugs like penicillin G and erythromycin are absorbed better, and they have increased bioavailability. Same information, that is when the pH is alkaline, weakly basic drugs are absorbed better, while the weakly acidic drugs, which are normally proposed to be absorbed better from the gastric pH, are absorbed little, that is the bioavailability is reduced. So the gastric pH decides the maximum concentration of the drug, while the gastric emptying time, it is prolonged at birth and it stabilizes by 1 week, and in infancy it is variable because there is often a gastrocolic reflex. So the maximum time achieved to the maximum concentration of the drug, the time taken to achieve the maximum concentration of the drug is increased. But here in infancy, the maximum concentration to be achieved with theophylline is decreased. So it is variable by age, not only by age, and also depends upon the feed that the child receives. High calorie feed, it can stimulate a gastrocolic reflex and it can alter the motility or the gastric emptying time. So the formula fed infants, they have a reduced gastric emptying time compared to the breastfed infants. Also the osmolality of the feed that is contained. This is based on this osmolality. The osmolality of ORS is reduced so that adequate absorption is permissible. This is the rationale for developing the low osmolality ORS for pediatric patients. Then based on the disease also, if there is any disease like Crohn's or any irritable bowel, that can also happen with children, and it can alter the motility of the gut. And drugs, prokinetic drugs, they hasten the emptying time. So they tried whether the gastric emptying time, when it is altered, does it alter the maximum concentration? So the AUC is unaltered. Only the time for reaching the maximum concentration is altered by giving a prokinetic drug. So the increased availability of paracetamol, phenytoin, and carbamazepine has longer time to achieve the maximum concentration. So the composition of intestinal fluids. What is the role of composition of intestinal fluids? Bile, the concentration, the secretion of bile is only 2 to 4 millimoles in neonates versus 3 to 5 millimoles in adults. Bile and pancreatic lipase have an important role in the solubility of any molecules or any active pharmacological ingredient that is administered to a child. So which is about 50% in the preterm. So drugs which are not soluble, that is variability in poor soluble drugs like hydrocortisone, and therefore decreases the maximum concentration that can be achieved in poorly soluble drugs. And 30% of highly lipid soluble drugs and vitamins alone are observed because the solubility is decided by pancreatic lipase and bile secretion. And again, another factor that interferes with absorption through oral route is the GIT permeability. In preterm, the GIT permeability is more. In term newborns, they are more than the first week of life because of the broader villi and decreased surface area. So the bioavailability studies using these xylose to measure the area under curve achieve maximum concentration in newborn. That is, the time to achieve maximum concentration is in newborn. And infants, this Tmax is multifactorial. The absorption and the GIT permeability is multifactorial. Rate constant, that is, the rate constant is not linear, non-linear with age. That is, every drug has a rate constant. The rate at which a drug is absorbed is called as Ka, or rate constant. It is non-linear with age, but the proportion of rate constant with the age ratio remains constant. So the role of transporters, there are active as well as passive transporters which are involved in the absorption of any molecule that is administered, and it alters the gut permeability also. These transporters mature by 4 months of age. And the transporters for lead, in infants it is about 40 to 50%, while in school children it is only 10 to 15%. Inferring that infants, when they are exposed to lead, they receive more toxic doses than the elder children, that is in the school going age. And bioavailability studies suggest transporter-mediated active absorption of certain drugs like phenobarbital, sulfonamides, and digoxin. And the transporter-mediated active absorption of nutrient macromolecules is arabinose and xylose. So the intestinal integrity is measured by sugar absorption test. That is lactulose versus mannitol, which is measured in urine after oral administration. This lactulose is absorbed through paracellular pathways, while mannitol is absorbed through transcellular pathway. So this decrease in lactulose versus mannitol ratio in urine from 2 weeks to 14 years of age shows thus as the child matures, more in the transcellular pathway of absorption is better. So absorption enteral is further influenced by the efflux transporter P-glycoprotein and also in the metabolism of the drug in the gut lumen. So the ontogeny of expression of efflux transporter, that is P-glycoprotein in the gut with age is very unclear. 3 to 6 months it takes to adult value by 2 years of age. This was one study, but it was contradicted by Fakuri and et al. So the metabolism, so the expression of P-glycoprotein is still uncertain, while the metabolism in the gut wall by CYP3A enzymes decreases the bioavailability of cyclosporin, nifedipine, midazolam, and verapamil. So the metabolism and excretion of digoxin within the gut lumen, when it causes loading dose alteration, it necessitates alteration in the loading dose. This is measured by the percentage of digoxin reduction products in urine. Whenever digoxin is administered, it undergoes metabolism in the lumen, and after metabolism, the balance amount is alone absorbed into the circulation. And after reaching the circulation, this digoxin reduction products are measured, which is about 1 to 3% in infants, needing a loading dose of 45 microgram per kg, while 7% in preschool children, and they need 35 microgram per kg. So therefore, it is 10% in school children and adolescents, while 25 microgram per kg. And in adults, it is 40%. So there is a gradual increase in the amount of or the percentage of digoxin reduction products in urine. That shows increase in the gut metabolism. But the children, the infants are very tolerant to high dose of digoxin. This could be attributed, this could not be attributed to the gut flora, and it cannot be explained, but it can be explained by an increased volume of distribution by increase in the myocardial to plasma ratio of digoxin, which is about 3-fold up to 3 years of age. And there is erythrocyte binding of digoxin also increases the apparent volume of distribution. So this could explain how the infants tolerate digoxin at a higher dose. So absorption through the parenteral route. Transdermal absorption is very much increased because of the underdeveloped stratum corneum, and there is increased hydration, and the body surface area to the volume proportion is high. Body surface area is high compared to the volume. And in preterm, it is 1000-fold in 30 weeks, and it drops to about 3 to 4-fold in 32 weeks. So we can see the rapid drop in the transcutaneous absorption, which is often used in preterm children, newborns with apnea, where they use theophylline as a gel, which is used as a to treat apnea. And in infants, because of this increased transdermal absorption, they develop methemoglobinemia when they are exposed to eutectic mixture of local anesthetics, and hexachlorophene in medicated soaps can cause neurotoxicity. And salicylic acid ointment, which is a component of benzoic acid ointment, causes salicylism. And aniline dyes pentachlorophenol in linen detergents, it causes cyanosis in the infants. And the advantage is, that is what I mentioned, is theophylline gel to treat apnea. And when we go for intravenous route, the rate and volume of infusion, it can alter the drug efficacy, as well as it can cause adverse drug reactions. And the challenges are infusion pump failures, how to calculate the rate, that may be very minimal. The IV set that is provided, it cannot be used to count the rate of infusion in newborn. So often we use the infusion pump, and that can also turn as a failure, or there may be overload of IV fluids. And IM we don't prefer in children, because whenever newborn or infants, when they are exposed to very painful episodes, then it causes hyperalgesia once they mature. So IM injections, it is painful, and also erratic absorption of the drugs. That is because of the poor blood flow, poor muscle mass, and weak muscle contractions. So what is the composition of body fluids? Before proceeding to volume of distribution, we are discussing about the composition of body fluids. based on the age. In preterm, the total body water is about 85%, while the fat content is only 1 to 2%. So in infants, they have the highest fat content of 30%. So the fat and water content have a greater impact on the apparent volume of distribution, as well as plasma concentration of the drugs. The water content decides the plasma concentration of the drugs, while fat content decides the distribution of drugs in the tissues. And there are special conditions in the pediatric population like protein energy malnutrition, dehydration, shock, and edema that causes wide fluctuations in this body composition, which in turn can affect the drug treatment or therapy with any drugs. So proceeding to distribution of drugs, the barriers one will be plasma protein binding. In plasma protein binding in pediatric population is decreased. The reason is one is decreased plasma proteins, like both albumin as well as alpha-1 acid glycoprotein. Also, the second factor is decrease in the binding capacity, decrease in proteins as well as decrease in binding capacity. Then there are certain conditions where there is decrease in the proteins due to disease like uremia, nephrotic syndrome, malnutrition, especially kwashiorkor, there is decrease in the protein content, and in liver disease, as we all know. And these conditions causes increase in the free drugs like warfarin and barbiturates. Warfarin is highly protein bound, and therefore the consequences of increase in the free drug can happen. So while ampicillin, ampicillin, and sulfasalazole, the concentration is increased because the plasma protein binding is reduced. So the plasma concentration of free drugs will be increased with ampicillin, ampicillin, and sulfasalazole. But here it is an advantage. The antibiotic levels are higher for even a lower dosage. Here, and also another different factor here is there is increase in the endogenous bilirubin. The endogenous bilirubin competes with the proteins for protein binding with sulfonamides, salicylate, and it can cause kernicterus. Kernicterus is this unconjugated bilirubin. It crosses the blood-brain barrier and affects the brain of the newborn, which in turn can cause adverse consequences for the growing child. So the infants, they have an increase in free drug, increase in apparent volume of digoxin, as we discussed in the previous slide, with longer t-half, and therefore the dosage interval alone is adjusted and not the dosage. Solubility of the drugs. Water soluble drugs increase the distribution and decrease in the maximum or the concentration max of protein bound drugs, because gentamicin, if it is highly protein bound and it is water soluble and it is retained in the intravascular compartment and in the interstitial fluids, then the maximum concentration is not achieved. So gentamicin, if the dose is based on milligrams per kg body weight. So there is increase in the extracellular fluid concentration of cefazolin, gentamicin, and linezolid, and the volume of distribution in neonates is more than the infants, because the total body water of neonates is more. And tramadol, they have conducted studies for distribution using 2-compartment model, and they found that there is increase in the central compartment distribution of tramadol. And other role is lipid solubility. Lipid soluble drugs, they get distribution have in the tissues, and it is also dependent on other factors like whether the drug is free or bound to proteins. And it also depends on the regional blood flow, not only on the regional blood flow, but also the perfusion of the concerned organ of distribution, permeability of cell membranes, and changes in the acid-base balance. The fat content is about 1 to 2% in neonates, whereas it is 22% at 12 months and 13% at 15 years. So the volume of distribution of highly lipid soluble drugs like diazepam and other general anesthetics are higher in neonates. So neonates, the body water is high while the fat content is less. So the neonates, the distribution is less, while in infants it is higher than adults. So the significant variation is for highly protein bound and lipid soluble drugs. So what are the transporters role? As we already know, P-glycoprotein, it is present in the lung and CSF. It affects the drug distribution in the respective tissues. While the P-glycoprotein present in the gut wall, it will interfere with the absorption or bioavailability of a drug. So metabolism, it can be either enzymatic or it can be blood flow dependent. When it is blood flow dependent, it is mainly in the liver. Then we call it as a hepatic extraction ratio. The main enzymatic sites of metabolism are in the gut, lungs, and skin, but liver is most intensively studied. The enzyme activity measured by microsomal protein content in liver in vitro. That is, how do they arrive that microsomal protein content in liver? How do they measure? It is by the autopsy samples of children, where the liver microsomal protein content is weighed and measured in vitro. So they found that the development of individual enzyme occur at different rates. And also the activity and expression also differs at different rates in preterm as well as term neonates. The CYP3A7 is replaced by CYP3A4 in infancy. And Heinz categorized these enzymes based on the in vitro data. The set of enzymes which are expressed in the fetus but silenced after birth, that is CYP3A7. That's why we told CYP3A7 is replaced by CYP3A4. And there are other enzymes also, flavin monooxidases and alcohol dehydrogenases. These are expressed in fetus but silenced at birth. And another category of enzymes are expressed in the fetal period but increase after birth, that is CYP2A6, CYP2C19 and CYP2D6. Expression in the third trimester with a substantial rise in the first 1 to 2 years of life, that is UGT, uridyl glucuronide transferase, N-acetyl transferase. This is very important because newborn child, when they are having hyperbilirubinemia due to hemolysis and they have unconjugated hyperbilirubinemia, which in turn can cause kernicterus. In that case, when you administer barbiturates, it induces the synthesis of uridyl glucuronide transferase, and therefore it conjugates the bilirubin to bilirubin diglucuronide, and therefore it becomes more water soluble and gets excreted. And that is how they are used. And the N-acetyl transferase and CYP1A1 and CYP2C9. Based on how do you derive it in vivo data? It is based on ontogeny studies. Ontogeny is nothing but the process of development that is done by using a probe drug, that is dextromethorphan or paracetamol. And this in vivo data can be derived by a serendipitous information from the clinical trials. Various clinical trials can provide a data of the levels of these enzymes based on the metabolism of the drugs or based on the serum levels of the drugs. So we'll continue here. The age-dependent clearance of theophylline, caffeine, carbamazepine, and valproic acid, it reflects larger weight to body weight. That is, liver weight is higher in proportion to the body weight. In adult, the liver weight is smaller compared to the body weight, but in infants and children, the liver weight is bigger compared to the body weight. The proportion is different, and this age-dependent clearance of these drugs is based on relatively larger liver weight to body weight, but there is no variation in the intrinsic clearance per gram of liver weight. The intrinsic clearance of the drug per gram of liver weight is not varied. Only the liver size based on the body weight, it causes increase in the clearance. So the extrapolation of adult dose resulted in gray baby syndrome when we use chloramphenicol, because the metabolism is different. This insisted the understanding of development of the metabolic pathway. Young children, they have a different metabolite, and so therefore the adult dose cannot be extrapolated into children, and this is a very bitter experience with chloramphenicol. And the enzyme expression as well as activity varies with the age, and this expression alters the metabolism of midazolam and zidovudine. That is, enzyme is present, but it is whether it is functioning and whether it is active, it determines the metabolism of midazolam and zidovudine. And a different metabolite is also produced. Certain drugs like valproic acid, paracetamol, chloramphenicol, and cimetidine, a different metabolite, not like adults. That is, paracetamol normally we go for glucuronidation, but in children they go for sulfatation. That is an alternate pathway. That is, phase 1 is activated, and therefore they can tolerate higher doses of paracetamol. Though the glucuronidation, that is the phase 2 enzymes, are immature, and the drug metabolites which are not produced by adults are seen in the pediatric population. Especially with caffeine, the metabolite is theophylline. So you can give caffeine, the metabolite is theophylline in newborn. And the intestinal colonization, it reaches adult-like composition by 1 to 4 years of age. Why intestinal colonization is important? Intestinal colonization, it can cause first-pass metabolism of certain drugs. And therefore, it can cause also, it is important in enterohepatic recycling also. So that's how this colonization is important to be considered when we deal about or discuss about metabolism. And the pattern of active enzymes in the first few months of life is different, and it reaches adult values in the 2 years of age. That is what we discussed about uridine glucuronide transferase activity, maturation is completed only by 3 years of age. Some amount of activity is there, but it is completely matured only by 3 years of age. And paracetamol, I told the children tolerate higher doses because they have alternative pathways of sulfitation. Besides that, they have a higher levels of glutathione. That is what we replenish when we treat paracetamol toxicity. And the blood flow dependent metabolism in the liver blood flow is relatively high in infants, and therefore it can cause increased elimination of the drugs that undergo hepatic extraction metabolism, that is propranolol. So the first pass metabolism by high extraction ratio for propranolol is increased in infants because of the relatively increased blood supply. And finally, clearance through metabolism, carbamazepine, midazolam, they reflect the CYP3A4 activity, that is 5-fold rise within the first 3 months of birth. Phenytoin, the half-life in preterm is more than 75 hours. In term, less than 1 week, it is 20 hours. Term, more than 2 weeks, it is 8 hours. So we can see the drastic fall in half-life. That means the metabolism is activated and the enzymes are more expressed and active. So the saturable phenytoin metabolism does not occur until the 10th day of life. CYP2C9 activity decides the half-life of phenytoin. CYP1A2 substrates, that is caffeine, undergoes 3-demethylation until the 4th month of life. So drug metabolism and age. Here there is a toddler overshoot, that is the toddlers have an increased rate of metabolism, that is called as toddler overshoot. See, when you see the tabular column, you can see that in preterm sulfitation predominates, in term sulfitation is there, but in infants, all the other metabolic pathways through CYP3A4, CYP1A2 and glucuronidation as well as sulfitation is increased, and therefore they are rapid metabolizers and they can tolerate little higher doses. But it should be guarded because the weight of the infants has to be always measured when we proceed with the dosing. So what are the brief list drugs and enzymes? CYP3A4 metabolizes alpha-fentanyl, ketoconazole, carbamazepine, midazolam and tacrolimus. CYP1A2 is involved in metabolism of caffeine and theophylline. 2B6 for cyclophosphamide and propofol. 2D6 for codeine and fluoxetine. 2C9 for ibuprofen and phenytoin, and it shows pharmacogenetic variations also. And with the CYP2C19 also, there is pharmacogenetic variations. So coming to the next part of pharmacokinetics, elimination. Elimination is based on the renal and hepatic function that develop over time. Preterm neonates mature in renal excretion slowly than term neonates. Creatinine clearance is almost equal to glomerular filtration rate. It is about 2 to 4 ml per minute in term neonates, and it doubles by the first week of life, and it reaches adult levels in 2 years of age. So there are certain drugs which are excreted based on the glomerular filtration rate maturation, that is morphine, paracetamol and dexmedetomidine. While certain drugs are excreted based on the renal weight, the number of units of nephrons, that is levetiracetam, cimetidine and cetirizine. And certain drugs are dependent upon the tubular secretion, which is immature until the first year of life. And here again, P-glycoprotein in the tubular cell has a major role in the secretion, tubular secretion of digoxin. Up to 1 to 3 years of a child, it needs 3-fold higher dose of digoxin per kg body weight than adult. And lastly coming is urinary pH. As we all know, urinary pH, it is acidic in adults, while in infants it is slightly less, that is it becomes more acidic, and it is less than that, that is more it becomes more alkaline, and therefore it increases the reabsorption of weakly acidic drugs. More acidic, and therefore it increases the reabsorption of weakly acidic drugs. And there are certain conditions which are very specific to the pediatric population, like hypoxic ischemic encephalopathy or perinatal asphyxia, patent ductus arteriosus. These will reduce the glomerular filtration rate by about 50%. And this because glomerular filtration rate is dependent on the renal blood flow. And therefore, when we treat newborns or neonates in pediatric intensive care units, we have to always remember that the glomerular filtration rate is reduced by 50% in these children with perinatal asphyxia or PDA. And we have to alter the dosage of the drugs which are excreted primarily dependent on glomerular filtration rate. And there is another method, that is total body cooling is also a method of treatment adopted for perinatal asphyxia, and it causes decrease in the morphine clearance. So the elimination is based on glomerular filtration rate, renal weight, tubular secretion, and urinary pH, and certain diseases that are very specific for the pediatric population, and one modality of treatment, that is total body cooling. So the pharmacokinetics of drugs and effects in short. So the example here is gentamicin has a volume of distribution that decreases with age. So higher dose to get the therapeutic peaks in children. Oseltamivir, it is a prodrug. It does not undergo conversion to the active drug and results in therapeutic failure. Codeine, when it metabolizes, it produces morphine, and this amount of morphine metabolite is unpredictable, and it can lead to accumulation and toxicity. Theophylline, there is increase in clearance and therefore increased dose requirements in infants and young children. Young children means 1 to 3 years. Phenytoin decreases the peroral absorption, and there is protein binding is there, and therefore decreased bioavailability and lower level. Levetiracetam is cleared more, and therefore increased dose requirement till 12 years of age. Methylphenidate, here it is clearance is reduced and therefore lower dose requirement. Benzyl alcohol is an excipient that undergoes decreased clearance, and therefore the chances for accumulation and produces fetal gasping syndrome. Excuse me. So the dosing information with regard to pediatric patients. Pediatric patients require specific formulations. Strength of the formulation as well as palatability. The clearance prediction based on adult values is not applicable to all the drugs or all the age groups. Obese children is an area of impending research because they are often encountered with toxicity to paracetamol. Paracetamol is not distributed in the fat tissues. Also, obese children, they are at times heavier than adults. So the dose should never be more than the adult dose. Hence, they are often overdosed, taking into account their actual body weight rather than ideal body weight. So the body weight based calculation is optimal from 1 month to 1 year. After that, body surface area is the better option to calculate dosage requirements. But no algorithm is appropriate for all age groups. Pharmacokinetic studies, they meet ethical constraints because as we know, pharmacokinetic studies, it is done in healthy volunteers, multiple blood samplings, which has ethical constraints when we apply for children, and therefore we have deficient dosing information. So surrogate measures and therapeutic drug monitoring help derive effective and safe levels of anti-epileptic drug therapy, especially, and therapeutic drug monitoring. But the failure on limitation of therapeutic drug monitoring is it fails to predict hepatotoxicity with sodium valproate. So formulations for a pediatric for a drug to be serving as a pediatric formulation, there are certain criteria. That is, it should have sufficient bioavailability. The excipient should be safe, and the palatability should be maintained, and dose uniformity. That is, how the medication or the active pharmacological ingredient should be distributed uniformly in the preparation. That is called as dose uniformity, and ease of administration, precise product information, and a parent or caregiver friendly, and additional guidelines for the novel functional excipients and new dosage forms. So these are the basic criteria which are assessed, and thereby formulations are permitted. So development of pediatric formulation is very less, and mostly children are neglected. Pediatric formulations, because they are very expensive to develop, they have many specifications, and the lack of appropriate formulation is also a contributory factor to medication errors. Errors in pediatric patients are tenfold compared to adults. A single vial, for example, a single vial of morphine contains more than 10 times the neonatal requirement. So there are chances of medication errors. How to take 1 ml if the solution is present in this vial means we need only 0.1 ml. So in that case, such errors are very common. And in recent years, the major advance is child appropriate formulations are encouraged. And population pharmacokinetic studies are used to derive dosing information and to derive formulations. The advantage of population pharmacokinetic studies in children is more number of children are exposed to a dosing and with minimal sample. That is why every child will be collected blood sample only once or twice. Each child will be giving one sample only, not multiple samples as in adults. So peroral formulations, we can go to solid formulations. Effervescent tablets, okay, they can dissolve and they can be dissolved in water and can be taken. But the disadvantage here is soda bicarb present in these effervescent tablets can cause GI malfunctions. And sodium and potassium content of these effervescent tablets is high, and it is contraindicated in children with decreased renal function or renal failure. And there is one mini tablet. The size is about 3 millimeter, and it can be easily swallowed by until 4 years of age. And there are altered forms, that is extended release and saliva resistant, because once you give a tablet, when it dissolves in the saliva, then the taste is dispersed throughout the mouth. So when the tablet doesn't dissolve in the saliva, then it can be easily swallowed. Then split weight. Split weight is nothing but when a tablet is administered for a child, for ease of convenience, a larger tablet is broken into pieces and it is administered in divisions. So this is the split weight. Split weight is at times it contains 50 to 150% of the actual tablet weight. So the actual tablet, the content of the actual tablet weight is not uniformly, if not uniformly distributed, then the half tablet which we give to the child may not contain the actual medication in the appropriate dose. So this is very risky, especially with drugs of narrow therapeutic index. So tablet geometrics and tablet scoring, that is, scoring is nothing but information on the divisibility, how many parts each tablet can be divided. And often we have the difficulty of administering a tablet to a child. So in that case, we often crush the tablets or separate the capsules and disperse it with some food items. So in that case, we use the multifunctional tablets, or those that can be split and swallowed or dissolved without any information, without any disturbance in the split weight. That is, split weight is the actual content, amount of the actual tablet weight that is distributed, that is not altered in multifunctional tablets. So there will be information. The scoring is nothing but the information, how many parts it can be split and swallowed without disturbing the actual tablet weight. And we go for extemporaneous formulation. That is, whatever I told, the tablet that is administered to children, for ease of convenience, we crush or open the capsules. That can affect the dosing, stability, and bioequivalence of the active molecules. So food ingredients, often we mix with the honey or milk. So these food ingredients also reduce the active pharmacological ingredient. The best example is 6-mercaptopurine. It is degraded in milk by the xanthine oxidase that is present in milk. So that reduces the bioavailability of the drug that is administered. And we have the last one that is called as enabling formulations. Here, the pharmaceutical industry, they give a diluent vehicle also along with the tablet, so that whether it is the choice of the child, it can take as a solid or it can be dissolved in the same vehicle that is provided. The best example is a fixed drug combination that is used in the treatment of malaria. So the best formulation that is often used in children is liquid formulations, and we have special deliveries also. Liquid dosage forms, it is very easy to administer, but the problem is palatability, because when we administer a liquid, immediately the bitter taste is spread throughout the mouth, and often it results in spitting and vomiting experiences. So the errors with measuring cups, that is 50% errors occur in cups with etched marks, and it is 30% in cups printed graduations. Here the cups will have a measure that is 2.5 ml, 5 ml. The measures will be markedly printed with graduations also. There the errors of administering the medication is lessened in cups with printed graduation. That is the administering spoon or the cups. And in 1 to 5 years, the maximum dose that is permittable, even if it is a liquid, is less than 5 ml. If it is 5 to 12 years, the maximum dose of the volume of liquid formulation is 10 ml. Advantage of liquid formulations is ease of administration and there is wide dose adaptation. Disadvantage is limited number of safe excipients, poor dose accuracy. As I already told, errors with cups. Issue of dosing devices. Aqueous solutions need antimicrobial devices. That is, they have to be prevented from contamination. And we have to mask unpleasant taste of active pharmacological ingredient, which is difficult. When it is a solid preparation like tablet, we can go for polymer coating, but when it is a difficult in liquid preparations. And we have oromucosal delivery, wherein, excuse me. In oromucosal delivery, the drug delivered will disintegrate in seconds. Example, antiemetics that is used in cancer chemotherapy induced nausea and vomiting, but the disadvantage is it is expensive. And we have dispersible tablets, thin film strips, and oral lyophilizates, that is wafers. And inhalational formulations. It is restricted only to lung diseases. And bronchial asthma is the commonest chronic condition in the pediatric population. The deposition of the active molecule or the real molecule is interfered by low tidal volumes in children, which interferes with the peripheral deposition, or the target point where the drug has to be reached is limited by low tidal volumes. Also, narrow airways prevent the entry of dry powders that are inhaled, especially in rota caps. The dry powder that is inhaled, it has a lactose as carriers. Lactose are larger particles that prevent entry into the narrow airways. And pressurized metadose inhalers are used. They deliver more amount of drug per unit dose, and it is delivered at a higher velocity. When we go for inhalational formulations for infants, always we should use a completely fitting face mask, whether you use nebulizer or spacer. Nebulizer is suitable for all ages. Some practical solutions. Doses should be in milligrams per kg body weight, and recording of the child weight is very important. Dose based on ideal weight. In cases where there is marasmus, there is total wasting. In kwashiorkor, there is edema and the child may be overweight, though it is malnourished. In nephrotic syndrome, as we all know, it is an edematous stage, so the child will be overweight. And the teaspoon measures is from 2.5 to 7.8 ml. So always instruct to use the measure provided, and measure that is provided with the drug that is supplied to them. Whatever drug they purchase, the same measure should be used. Formulation. Drops when they are prescribed as ml. As a previous speaker told, drops when they are prescribed as ml, it will lead to toxicity, especially in children less than 6 months of age. And always double check the dose calculation, both by the prescriber as well as the pharmacist. Doses should be rounded to enable parents and caregiver give it accurately. And to ensure compliance, the dose frequency has to be reduced to least possible to avoid spitting and spilling events. And long-term treatments for children, when they grow, the dosage has to be adjusted. Optimum dose is arrived by adjusting the recommended dose based on the therapeutic response that is observed over a period of time. So addressing compliance issues. When it is peroral, children less than 6 years have distinguished taste perception, and they are very aversion. They have very aversion to bitter taste. So development of taste relevant API, that is active pharmacological ingredient, or excipient is important. Taste masking strategies by film coating with polymers or sugars. When it is coated with sugars, it is called as draggies. Parenteral. What are the compliance issues? We have to get improved injection devices with fancy design when we administer growth hormone or insulin. Insulin it is in type 1 diabetes patients. The peak spurt is in 1 to 7 years. That is one peak spurt, and another peak is a pubertic. So they will have some stigmatization or uneasiness, and they may feel they may miss the injections. So we have to develop devices with fancy designs with growth hormone and insulin, and transdermal patch with fentanyl. And there are children who, when the dosing is frequent, then they may have to take a medication in the school when they are in the school. So to avoid that stigma of school dosing, oral osmotically releasing pulsatile system, that is followed with methylphenidate formulations, and the delayed release formulations which contain mixed coated as well as uncoated pellets. So they can release the drug at a slow rate, and therefore a midday dosing can be avoided, and it can ensure the compliance. Then we can move to pharmacodynamics. What are the responses that are different in children? The glomerulotubular imbalance, that is decrease in the concentrating ability, that has its advantage as well as disadvantage. The disadvantage is there is risk of salt and water wasting, but the advantage or positive aspect here is they are less nephrotoxic to less nephrotoxicity of aminoglycosides and furosemide. And thiazide as a diuretic is less effective compared to furosemide because the sodium chloride transporter is not mature in children. And there is paradoxical excitatory effect of GABA, that is increase in the chloride ion in immature neurons. When the neurons are immature, this GABA or the chloride ion channel, instead of hyperpolarizing, it will be in a depolarizing state. The shift from depolarizing to hyperpolarizing type of ion channels, it is done by or mediated by sodium potassium co-transporters, NKCC type 1 transporters. So another change is paradoxical or delay or failure in closure of patent ductus arteriosus. When we administer cyclooxygenase inhibitors in the antenatal period, then there is delay or failure in the closure of PDA, because not only due to prostanoids, but also due to this L-type calcium channels and potassium channels, which are influenced by this early administration of COX. And phosphodiesterase inhibitors also have a role in closure of PDA, and therefore they are not recommended in, that is milrinone not indicated in cardiac failure in newborn. And retinopathy of prematurity is a disease which is very specific for the newborns who are exposed to high oxygen content during their newborn during their period in the PICO or NICO. So docosahexaenoic acid has shown to be protective effect from developing this retinopathy of prematurity. And dexamethasone, it is neurotoxic in high doses in the first 96 hours of life. When dexamethasone is administered for children with transient tachycardia neuron or respiratory distress syndrome, which is part of the evolving process, then it can cause neurotoxicity, which may manifest in later life. And the one important point here is analgesic dose of morphine is 5-fold compared to the dose that produces respiratory depression. So when we should be very careful when we opt for morphine as an analgesic, because analgesic dose is higher, but the dose that produces respiratory depression is lower, and therefore when we go for morphine induced analgesia, we are sure to produce respiratory depression. Phenytoin barbiturates are neurotoxic to the developing brain. Midazolam, it causes paradoxical effect in neonates, that is, it causes myoclonic seizures because of imbalance in the GABA subunit versus the benzodiazepine subunit, and therefore flumazenil is used to treat here. Antipyretic effect of paracetamol is greater in infants because of the larger body surface area, because skin is the point where heat is dissipated. And children who are 1 to 5 years, when they are administered non-cardioselective beta blockers for prevention of arrhythmias like nadolol, they can land in hypoglycemia. This is due to dysregulation of beta receptors, beta 2 receptors, and there is maturation is also very poor, and there is poor intrinsic hepatic gluconeogenesis in the newborns, that is 1 to 5 years children, young children. They can develop hypoglycemia. And there is augmented response to warfarin due to decrease in protein C and prothrombin. Protein C and prothrombin are prothrombogenic. So that is decreased in children, and therefore they can produce an augmented response to warfarin. There are changes in immune function where we use surrogate biomarkers like cell proliferation and interleukin-2 expression to measure the extent of immunosuppression following immunosuppressant drugs, of which infants and 2 to 7-year-old children, they are highly sensitive. There is increased sensitivity to cyclosporin. And growth retardation with inhaled glucocorticoids, irrespective of the hypothalamic pituitary axis suppression. We always think that the HPA suppression is the root cause for growth retardation, but studies have shown that growth retardation occurs irrespective of HPA suppression. And doxorubicin, which is often used in pediatric malignancies or hematological malignancies, it can result in 2 to 5-fold increased cardiovascular toxicity in the survivors of cancer chemotherapy. And smoke exposure, it may be active or passive. It alters the N-type of or nicotinic acetylcholine receptors in the brainstem, and it can result in sudden infant death syndrome. Even antenatal exposure to smoke alters this nicotinic acetylcholine ACH receptors and causes sudden infant death syndrome. And bronchiolitis, it is a disease usually common in the infants, and there is poor response to the beta agonist because of decreased sensitivity, decreased number of beta 2 receptors. Also, there is responsiveness to prostanoids. So these are some differences from adult to children. And moving on to pharmacogenetics, here I haven't discussed much. The genetic factors, they alter the drug metabolism as well as the development of drug receptors. So the limitations of pharmacogenetic study is ontogenic differences in the metabolic pathways and development. We cannot stick on to pharmacogenetic study in one specific age group alone. The entire age group has to be studied, and the development has also been parallelly measured, and that is the limitation. And pharmacogenetic study, it can evaluate the efficacy as well as toxicity of the drugs, and they have done such studies in with the 6-mercaptopurine. Thiopurine methyltransferase, when there is reduced activity, it causes bone marrow suppression, but when the activity is increased, it results in hepatotoxicity, and therefore, but effectiveness is reduced. So they have finalized that all children before a standard dose of 6-mercaptopurine for acute lymphoblastic leukemia, they should be tested to prevent this toxicity. And genetic variations in the CYP enzymes in the breastfeeding mother can cause toxicity in neonates. That is, the mother is a different has a different genotype for CYP enzymes that can in turn affect the child who receives the breast milk from that mother. Rapid metabolizers versus ultra short metabolizers, slow metabolizers. So the toxicity in neonates depends on the metabolizing rate of the feeding mother. Some common adverse drug reaction in pediatric patients. Neonates, they are prone for kernicterus with sulfonamides due to protein displacement of bilirubin. Chloramphenicol, as we already discussed, due to impaired metabolism causes gray baby syndrome. And povidone iodine, that causes povidone iodine should not be used for a surface disinfectant or a surface protect before surgeries in neonates. It causes thyroid dysfunction. Neonates and young children, they are prone to calcium precipitation in the lungs when ceftriaxone and calcium containing solutions are mixed together and administered. And sodium valproate can cause hepatotoxicity, and this toxicity is not predictable by therapeutic drug monitoring. And children, when administered propofol, they develop propofol infusion syndrome, and the dose relation to this development of this syndrome is still under question. Bigabatrin produces visual field defects that is produced even in adult also. Hydrocortisone is poorly soluble, and the water solubility is different, and also it causes growth retardation, though it is short acting. Adolescents, when they are administered metoclopramide, they produce dystonia. The mechanism is not clear known. There is increased incidence of dystonia. Excipients, often when we go for formulations, excipients are added. So excipients induced ADR in pediatric patients. That is when the excipients they exceed the acceptable daily intake. That is fixed by Joint Expert Committee report. That is the Joint Expert Committee of Food Additives. That is nothing but WHO and Food and Agricultural Organization. They both together, they form the Joint Expert Committee, and they have derived at a report fixing the acceptable daily intake of these excipients. So when they are exceeded, then it results in certain toxicities in children. Benzyl alcohol, when it is excess in the under 6 months age group, they are at risk causes neurotoxicity. Aluminum salts, common in children with renal failure and they undergo dialysis or when they are administered antacids. So it can cause metabolic acidosis. Propylene glycol or diethylene glycol, when it is given in the formulation for less than 12 months, it produces hyperosmolarity and seizures. Menthol produced in any route causes bronchoconstriction. Benzalkonium chloride, when it is exposed to less than 18 years in any route, causes bronchoconstriction. Parabens are totally deleted from the excipient list. Sulfite and bisulfite causes hypersensitivity in all age groups. Phenylalanine, this is very specific because phenylketonuria is a disorder in the child. So these children, they should not be given phenylalanine or aspartame. Aspartame is often component of sweetening agents, and therefore we should not prescribe these sweetening agents to this group of or any drug that contains aspartame as an excipient should not be given to children with phenylketonuria. So monthly, when phenylketonuria is ruled out by a screening test, you can give this because it causes cognitive and behavioral disturbances. And polysorbate 80, that is often used in parenteral formulations, should not be administered for children less than 1 year. It causes E-ferrol syndrome. And pharmacovigilance, we have seen all the areas. Now how to make it as a report and ensure safety, how to understand that. So pharmacovigilance in children. The children, they are more prone for adverse effects. The potential for adverse drug reactions in infants and children is greater than adults. As we all know, depends upon the dosage, limited information on dosage, formulation causing medication errors. And children, they experience a wide range of adverse reactions which are different from that of the adults. And most adverse drug reactions are undetected due to poor recognition. They are poorly recognized. And the ADR in outpatient settings are often underreported. In hospital settings, it is quite better. The meta-analysis of 9 studies of adverse drug reactions in children showed in inpatient setting, the incidence of adverse drug reaction is about 9.5%, of which 12.3% is severe. In outpatient setting, the incidence is 1 to 1.5% of drugs that are used in result in adverse drug reactions. So the pharmacovigilance of off-label used drugs, because exposure to unlicensed use is about 42%. Children are exposed, that is 42% of children are exposed to unlicensed use of drugs as outpatients. And therefore ADR is very common among the off-label use, that is about 2%. And orphan drugs are drugs that are administered to a very limited number of population, that is 2% children are exposed and they also develop ADR. That is the number of ADRs to the children who are exposed to orphan drugs is about 2%. So active surveillance for a specific drug risk management program is very need of the hour, because more number of drugs, globalization of marketing, and any drug that is newly marketed is available in every country. And therefore, we have to go for a specific drug risk management program, that is signal detection by case reports. Previously unrecognized safety issues has to be recognized, and new scale of severity of a known issue. That is signal means previously unrecognized safety issue as nothing but a toxicity or an ADR. And a new scale of severity. Previously it was a mild reaction. Now it has become severe. That also comes under signal detection. And identification of a new risk group. That is previously a specific age group was told to be at risk, but a new group is also at risk means then it becomes signal. So what are the methods to detect ADR? By spontaneous reporting. Intensified monitoring is very important in a pediatric intensive care setting as well as in a inpatient setting, and prescription event monitoring that has an important role in outpatient setting, and case control studies, post-marketing surveillance studies, and large data resources can be analyzed by meta-analysis, and some useful information can be derived for the frequency and severity of occurrence. And clinical trials. Clinical trials, they give information based on the adverse reactions to the drugs under trials. So vaccine vigilance, because children are exposed to more vaccines than adult, and the vaccine development manufacturers nowadays, they are instructed to follow pediatric investigation plan. Only when they submit the pediatric investigation plan, they are permitted to proceed with the vaccine development. So therefore, this is regulation is imposed to protect the rights of the children as active subjects. And adverse event following immunization. So the case definition is very important to analyze the temporal or causal association. So this case definition is provided by Brighton Collaboration. It is an independent organization for standardizing vaccine safety assessment. It is still under validation only. This is done to identify, evaluate increased frequency of occurrence of adverse event following immunization. And this is done by intensive adverse drug reaction reporting and dissemination of information to the public, because it happened many times that certain vaccines, they produce some adverse effects, but the temporal or causal association was not established, or it finally turned out to be a coincidence. It happened with mumps, measles, rubella vaccines and certain other vaccines also. But the public were got an information from social medias that this vaccine produces this much amount of adverse effect. But finally, the report turned out to be a coincidence. So whatever information that is gained after analysis of an adverse event following immunization, it has to be shared or disseminated to the public to ensure continuation of the vaccine as well as national health policies. So going to therapeutic drug monitoring, it is important because validated dosage recommendations are very limited. So we have always to prevent therapeutic failures as well as toxicities, TDM is important. And there is inter-individual variability, age-based variability in the pharmacokinetic and pharmacodynamic characteristics. So pediatric dosing is always empirical. It starts as empirical, then it is supported by various values from clinical trials, TDMs, and other pharmacoepidemiologic studies, so that the dose is finalized. So it is empirical, and therefore there are more chances for therapeutic failures and adverse drug reactions. So, and I already told that unlicensed or off-label use of drugs is about 70% in children, but in neonates it is 93%. So you can expect what amount of new drugs or unlicensed use is practiced. Then pharmacodynamic monitoring is also done in pediatric therapeutics. That is, with calcineurin inhibitor therapy, the immunosuppression is measured by markers, that is cell proliferation and interleukin-2 expression. And with anti-epileptic drugs or anti-hypertensive drugs, we can measure through pharmacodynamics. That is, by maintaining a seizure diary, the number of occurrence of seizure episodes can be reduced or measured. And anti-hypertensives, we can measure the blood pressure. But with the analgesic effect in young children and neonates, so a validated pain scale is required. And for therapeutic drug monitoring, it is not applicable in drugs with saturable metabolism. Certain technical aspects are there when we go for therapeutic drug monitoring in children, because children have a higher hematocrit, that is, the blood is more thicker. The hematocrit is higher, and so more volume of blood is required to generate plasma. So we often measure blood levels in plasma. So the hematocrit is higher, so more volume. But by ethics guidelines, we cannot draw more than blood. That is the amount of blood that can be withdrawn over a period of, that is 1 point of time, it should be less than 1%. So these are the constraints. Volume of blood drawn should be least. The total volume of blood in a newborn is about 40 ml. In that case, how can you withdraw? That is 1% only can be withdrawn at 1 point of time. So you can imagine what will be the restrictions. So we opt for immunoassays because they require the least amount of blood sample, and they are very specific. But the disadvantage is the antibodies that are used in immunoassay, they often cross-react with the drug metabolites also, and it results in overestimation of the drug molecule. Say for example, mercaptopurine, mycophenolate acid, glucuronide. Mycophenolate mofetil, when it is administered, it becomes mycophenolic acid. And the glucuronide, it is often assayed by enzyme multiple immunoassay technique. The antibody cross-react with this metabolite, and it causes an overestimation of the measure of drug. And what are the matrix that can be used for therapeutic drug monitoring is saliva, plasma, or dried blood spots. Saliva is non-invasive, that is advantage, but certain drugs, they have equal levels. Saliva level is equal to blood levels, that is carbamazepine, phenytoin, and ethosuximide. But the limitation is the flow rate, pH. Protein binding affects the estimation of valproic acid in saliva. And the dried blood spots. Here, very minimal amount of blood is required and it can be easily accessed. The process of collecting blood is a big issue in pediatric population, and therefore a finger or heel prick is enough to collect less than 100 microliters of blood. And also this dried blood spot in a filter paper can be transported to the lab, and by the time the child visits the pediatrician, the report will be ready. So this is simple to transport, and the hematocrit alters this blood levels when they are measured through dried blood spots. This is especially important with antiretroviral therapy, immunosuppressants, and anti-epileptic drug levels. When they are measured, this hematocrit changes with growth, alters the amount of drug level, especially with antiretroviral drugs, immunosuppressants, and anti-epileptic drugs. So the amount of blood that is required is also higher, and therefore, when the hematocrit is higher, the permeation of the blood into the filter paper is poor. And the other method is chromatography, that is high performance liquid chromatography with UV. But the disadvantage is positive bias in 15% of transplant recipients. So finally, HPLC coupled with tandem mass spectrometry, it is used for this same dried blood spot analysis. When it is tested with HPLC coupled with tandem mass spectrometry, has the best advantage. But the problem is it is expensive. And the newer approaches for TDM is we go for population-based pharmacokinetic data. The optimal interpretation, it needs validated therapeutic range. So how do we arrive at that validated therapeutic range? The lower limit of the range is the concentration that elicits half of the therapeutic response, while the upper limit of the range is the concentration that is toxic or to least number of exposures. Exposures is nothing but the patient who gets the drug. That is toxic to least number of exposures. So like LD1, that is toxic to lethal dose 1. Likewise, here it is toxic dose 1. So the lower and upper limit of the therapeutic range is fixed, and whatever values that we come across is validated. So the drug exposure measured based on validated pharmacokinetic parameters, these in turn reflect the therapeutic response. So this therapeutic range means we can expect the therapeutic response. So, but in case of non-linear mixed effect modeling, we have to derive the therapeutic range and correlate it with the therapeutic response by parametric methods and covariate analysis that is used in prediction of therapeutic range to therapeutic response. And another method is Bayesian estimation. It is more flexible, and the sample that has to be collected for therapeutic drug monitoring, that the timing can be adjusted. More flexible sample timing, and there is precision of the inference. This can the Bayesian estimation has to be validated. When there are small number of patients, it is called internal validation. When large number of patients, it is called as external validations. This internal validation is done by circular permutation. This area under curve guided therapeutic drug monitoring. That's what I told. The pharmacokinetic data that is derived, it can guide the therapeutic drug monitoring of certain drugs like mycophenolate mofetil, cyclosporin, and carboplatin. There are inter-individual pharmacokinetic variations that are observed with methotrexate, gentamicin, and tobramycin. So when we go for TDM of these drugs, we have to remember there are inter-individual PK variations that require more number of data and more number of references before arriving at a or before correlating therapeutic response and therapeutic range. So going to the rational use of medicines, irrational use is very prevalent both in high as well as low income countries. So the pharmacoepidemiological studies of drug usage in children, it can provide a useful input. So as pharmacologists, we can think of these studies. Pediatric clinical pharmacologists can play an important role in such studies, and the data that is derived can contribute to the rational use of medicines. Health professionals should be updated whenever any scientific information is derived. It has to be disseminated to the health professionals when there is scientific evidence. And the use of pediatric dosing reference, just like any formularies, that is, they have derived a British National Formulary for Children, guidelines by National Institute of Clinical Excellence. These are all pediatric specific formularies. National formulas. In India, there is a quarterly web publication by Indian Academy of Pediatrics, web update and web edition of drug formulary. And WHO has released the list of essential medicines for children, that is called as EDLC, that is updated till August. And rational use of medicine, it promotes financial benefits for the government and health system, and it improves the patient outcomes as well as safety. For rational use, certain studies are needed to derive complete data, then pediatric dosing reference from national formularies, and you have to, the list of essential medicines for children can be referred. So kids list. Kids list is key, the list of drugs which have the key potential for inappropriate excuse me. It is the list of drugs that produces adverse effects in children. How it is derived? The list of drugs is used in children is derived from systematic review, lexicon database, and FDA delivered or issued pediatric safety communications. So they derive a list of drugs. This list of drugs is again literature review is done for the above list of drugs. And after literature review, it is submitted for panel discussion for strength of evidence. And based on strength of evidence, recommendations are made. So the strength of evidence as well as recommendations can be strong or weak. That is, if the adverse effects are very severe, then they make strong recommendations. If the strength of evidence is high, they also again make strong recommendations. After this panel discussion, it is submitted for the expert review. That is, out of panel members, pediatricians, pharmacists, and staff nurses who can provide some more information regarding the adverse drug reactions to the list of drugs that are provided. And finally, there is an open comment period that is provided by the for an open comment from the Pediatric Pharmacy Association. Finally, they have arrived at this kids list is finalized, which consists of 67 classes of drugs and 10 excipients. So these drugs has to be used with caution or avoided. These inappropriate drugs in pediatrics, which are strongly recommended, are mentioned here. Chlorhexidine, it can cause chemical burn, and therefore it should be used with caution in low birth weight and neonate babies, that is surface cleaning. Valproic acid can cause pancreatitis and hepatotoxicity, and therefore it is avoided in children less than 6 months and has to be used with caution under 6 years of age. Dicyclomine and atropine can cause apnea and respiratory depression, therefore avoid in less than 6 months as well as 6 years. Tricyclic antidepressants of desipramine can cause sudden cardiac death, avoid in children 1 to 6 years of age. A topical preparation, gentamicin ophthalmic ointment, it can cause severe ocular reactions in neonates. Dopamine antagonists can cause acute dystonia and respiratory depression in infants and death after intravenous use, and therefore it is cautioned in children. Indinavir causes nephrolithiasis, and therefore it is avoided in children. Olanzapine causes metabolic syndrome, and therefore not more than 24 weeks of therapy. The longer duration can increase the chances for metabolic syndrome. So what are the regulatory changes? Quality is a major challenge in proportion to the cost of medicine production. So WHO has rigorously assessed the suppliers as well as the products, especially for generic medicines. So pre-qualification is important. When a manufacturer or goes to go for a product that is to be issued in any national health policies, it has to be assessed by WHO, and a pre-qualification certificate has to be received. And this is important with diseases like HIV, tuberculosis, malaria, and zinc tablets that are used in children also, and whatever drugs that are mentioned in the essential drug list for children. And the wholesale prices and generic medicines list from not-for-profit suppliers is provided by WHO website, that is provided here. And there are certain scientific studies when they have documented off-label use in drugs in pediatrics, and they have derived at some evidence means that has to be shared and that has resulted in label changes. And there are certain encouraging incentives for pharmaceutical industries to go for study medicines in children, more drug development, which have some focus on children also, because children are also potential users. In that case, a 6-month patent expansion for new medicines that are developed, and already if there is a patent, then that is no longer patent protected. That is, the period of patency has expired. In that case, a period of market exclusivity, that is called as pediatric use marketing authorization, is provided as an incentive for the pharmaceutical industries to study medicines or develop medicines which are useful in children. But nowadays, even now, the clinical trials with the more financial benefit for the industry rather than benefit for the pediatric patients are used or developed. And certain legislations are there for pediatric trials. They have to study all new medicines except me-too drugs in children. And the pharmacokinetic studies, as I already told, it is different from the adults. It should be least invasive, like collecting samples of urine or saliva to measure the blood levels, or sampling to be minimum if it is invasive methods. And the blood loss should never be more than 3% of the total blood volume in a period of 4 weeks, and not more than 1% in a single prick or a single instance. And alternative to pharmacy studies, that is already told, population pharmacokinetic studies, physiology-based pharmacokinetic studies, and simulation-based pharmacokinetic studies. Here, only 1 or 2 samples are collected from each child. And there are other non-invasive methods like caffeine breath test, but the caffeine breath test is expensive and it involves the use of a stable isotope. Safety in clinical trials in children is essential because they have faced many significant toxicity in clinical trials. And therefore, independent safety monitoring board and data safety monitoring committee are now mandatory to proceed with pediatric clinical trials, testing new drugs in pediatric patients. And the pediatric clinical pharmacology is emerging as a subspecialty, where they provide training in study of efficacy and toxicity of drugs in children to understand and generate scientific evidence by clinical trials as well as data from the pharmacovigilance. So the Western countries have recognized this training program, and accreditation is also derived. The European Society for Developmental Perinatal and Pediatric Pharmacology, it promotes funded global research in pediatrics. So we can opt for that with agreement to exchange information gained in different countries. There is global sharing of information for the benefit of patients. Pediatric clinical pharmacologists, they associate with clinical pharmacists and other disciplines to derive this information. Major initiatives to improve pharmacotherapy in children are: one is formulary, the British National Formulary for Children, then European legislation encouraging clinical trials of medicines in children, and the establishment of Medicines for Children Research Network. So these are the major initiatives to protect children during pharmacotherapy. So the take-home message is: apply knowledge to safe drug administration to child first at home. Understand the evolving metabolism as the child grows. Dosage is key to success as well as safety. Monitoring of adverse drug reactions is very important in children, as well as adverse event following immunization. Prompt reporting and analysis is very important. And therapeutic drug monitoring or pharmacodynamic monitoring is also useful to prevent toxicity and follow for therapeutic response. And remember the contribution of pharmacoepidemiologic studies in pharmacotherapy of pediatric population. And clinical research can also improve therapy. References. Okay, thank you for the patient listening. Madam, unmute, madam. Madam, audio is Unmute, madam.
Kekala. Am I audible?
Yes.
So we would like to thank immensely from the Department of Pharmacology, Kilpatrick Medical College, Dr. Vijayarani, for this excellent presentation. Again, I request the participants, if you have any queries, you can raise in the chat box. The speakers will be able to answer that. I will be passing on the answers to you. Thanks a lot. Excellent presentation. I would like to thank you in person also. We'll meet again. At this juncture, we are happy to have our previous speaker, Dr. Kurandayamma, HOD, Stanley Medical College, who joined us physically after the session. So we would love to honor her with a small memento from the Department of Pharmacology. Come. Yes, Karina. Photo எடுக்கிறீங்களா? Yes, thank you. So it's a great pleasure. I would like to thank, on behalf of my team, all the speakers who have done a wonderful job today. I would like to call upon Dr. Sharmila, our Associate Professor, to deliver the vote of thanks. Before that, I'm sorry, the results of the quiz is waiting. Yeah. Now the quiz winners for the pediatrics. We have Ariyara Sudan from SRMC, who wins the first prize in the pediatric pharmacology. The second prize goes to Dr. Sharan Sneha from MMC again. And the third, Dr. Valdali Navya from Postmania. So we are very happy to have all of you who participated in the quiz. We congratulate all the participants and congratulate all the winners in the quiz competition. You will be receiving your cash prize through GPay. Thank you so much for being with us. I hand over the mic to Dr. Sharmila for official vote of thanks.
Good evening to one and all. It gives me great pleasure to deliver vote of thanks on behalf of our Department of Pharmacology. First and foremost, I thank our Dean, DME OSD Madam, Dr. Shanti Madam Ma'am, and our Medical Superintendent and our Vice Principal Ma'am. Thank you, Ma'am, for organizing this webinars CME. And also I thank our, my sincere thanks to our speakers, that is our directors, Madras Medical College, Dr. Ramachandra Bhatt, and Dr. Kurandayamma Ma'am, Stanley Medical College, HOD of Pharmacology, Dr. Vijayarani Madam, HOD of Pharmacology, Chengalpattu Medical College, and also HOD of Pediatrics, Dr. Lata Ravichandran Ma'am, and SRMC, and also our international speakers, Dr. Ramesh, and also Dr. Soviet Selvi Ma'am. I thank everyone for our wonderful CME, for conducting our wonderful CME and accompanying with us without any hesitance, and accepting our topics and presenting it. And also thank our assistant professors and our I thank our HOD ma'am, and as a team leader, and heartfelt thanks to her, and also my assistant professor and PGs, and also our Shield Healthcare for our conducting our CME in a successful manner. And also finally thank all the audience who are participating with the enthusiastic participation in the CME. Thank you once again. I thank you all.
All good things must come to an end. Likewise, our session for today is also concluding. All the e-certificates will be sent to you. Thank you one and all for your patient listening and your cooperation for making our webinar a successful one. Once again, thank you. Let's disperse for today. Thanks.
மேம் என் பண்ணிடலாம் மேம். ஃபீட்பேக் ஃபார்ம் கேட்டிருக்காங்க மேம். யார்? ஜெயஸ்ரீ மேம் கேட்டிருக்காங்க.
Just share your feedbacks in WhatsApp group. We haven't created one in WhatsApp.
To அவங்களுக்கே போட்டுருங்க.
Please share your feedbacks in the WhatsApp group போட்டுருங்க.
Okay. இன்னும் 30 பார்ட்டிசிபென்ட் இருக்காங்க. யாருமே இன்னும் இல்லை.